You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. You know what? I just realized we should probably update that intro.
To what?
Jonathan's not the only one living the EMS life anymore, and we're no longer in school.
Well, yeah.
But hey, that's a good thing.
Anyway, welcome everyone.
Welcome everybody to the Ride Along EMT School podcast, episode number 32.
Boulevard of Broken Bones.
Boulevard of Broken Bones. What are we? We're talking about some fun stuff tonight.
We are.
What are we doing, Max?
Musculoskeletal injuries.
Ooh, almost got the word correct.
Almost. I came close. I got it the second time.
Musculoskeletal.
Yes.
Musculoskeletal.
I mess it up every single time I try to say it.
The bones and things connected to the bones.
Musculoskeletal. I feel like I'm. What is the dude's name from He-Man?
Skeletor?
Skeleton. Musculoskeletal.
His memes are awesome.
Yeah.
Until we meet again.
Yes. I love those things.
But you know what? I'm going to, because I know we can start getting into our little chats, our little side quests, if you will. Before we do, I want to make sure that we call out our sponsor for this episode.
Absolutely.
Because they have been very patient with us, and we have been waiting a long time to get to this episode, to really kind of partner with a company that we've become very fond of on this podcast. And that is Sam Medical.
Yep.
Now, if I asked you to dig in the first in bag and grab me a splint, what immediately comes to mind? Because I'm pretty sure just about any provider would reach in and come out with a rolled piece of aluminum covered in foam, blue on one side, orange on the other. And if they handed it to me, they probably wouldn't just call it a splint. Because in EMS, when you say the word splint, it almost feels incomplete unless the word before it is SAM. But the story of Sam Medical doesn't stop there. From the SAM XT tourniquet to pelvic slings, bleeding control products, and innovative trauma care solutions, Sam Medical focuses on building equipment designed specifically for the realities of pre-hospital medicine. Their gear is trusted by EMS providers, military medics, and rescue teams around the world. Because when the stakes are high, there's only one name many of us think of first in trauma: SAM. To learn more about their full line of trauma care products, visit sammedical.com.
I mean, they have been unbelievably generous to us and a continued sponsor and provider of things to first fill our bag and also to show people and to use in classes.
Well, more than any of that, they've helped us then kind of bring information and knowledge to everyone else.
Because whether you don't know this, maybe, but they've been training us as well on how to use each one of these things.
Yes.
So not only do they have the product, but then they also are training us on how to use it properly. So I cannot say enough good things about a company that puts its money where its mouth is.
Yeah. They're great.
Yep.
Jonathan and I got to sit in on some training sessions with Bob Waddell, who is their training director, as well as Todd from their sales team, who I got to meet at EMS World Expo. Amazing people. They have a dedication to education that I'm just flabbergasted by.
Hey, that rhymed.
Did it? Okay, cool. Not even intentional.
No, I mean, they've been awesome.
They're really great, and they've been teaching us so much, and they become a huge resource. And Bob specifically, who is a former provider level paramedic who retired from the street and moved on to working in the corporate world for Sam. If you are interested, I just got to have an amazing interview with Bob that will be being released just days after this episode airs. So if you want to check that, I encourage you, please, to check it out. Bob's an amazing guy. He talks a little bit about what Sam is as a company and what it was like growing up in EMS from the 1970s. He got into EMS as a paramedic like at age 14 in like the late 1970s. Like we're talking the early infancy of EMS. So he kind of grew up with EMS and had some really great insights, some old school, insights into the world that we've now adopted and has adopted us. And he's just a really great guy to listen to. And whenever we talk, it winds up being like 4 hours long because he's just such a great guy.
No, I mean, the fact that you were able to talk to the guy that invented it is pretty amazing.
Oh, no. That's Sam Scheinberg.
Okay.
This is Bob Waddell.
Okay, sorry.
So hopefully I'll get to meet Sam at some point and his wife Sherry, who are apparently the nicest people ever and really supportive of the whole community. But Bob's their training director.
Okay, gotcha.
Or training manager.
But yeah, I'm looking forward to seeing it. I wasn't able to be there for it. I had to work, which is just,
Max always has to work.
It's crazy. Yeah, stuff. Anyway, but yeah, so awesome.
Yeah, so
awesome.
Sam Medical, they're helping us out. And little tidbit, if you stick around for the end of this episode, our tools of the trade section, we're talking the Sam Splint.
I mean, we all know that you turn this off until the student tip.
Yeah, they fast forward right to
we
right to that
understand
section.
but maybe pause like a little bit before that and check out tools of the trade because we'll be talking about these things.
Yeah. It's good stuff. I mean, Sam does so much stuff in the trauma space, and we're in our trauma block.
Yep.
That's why we've been so excited to talk about them and all of this stuff, because let's face it, trauma is the sexy aspect of EMS, sure. I guess. Although I will say the medical, I think I've probably mentioned this before, I learned more on the medical side going through school. But trauma is the thing that, like, it's the lights and sirens, it's the adrenaline rush. Yeah. It's the stuff that looks gruesome. It's the things that we think of.
And it's the stuff that we were the most familiar with going into, which
some of us,
was a really good reinforcement. I mean, for you and me, it was a really good reinforcement of, and also got rid of some preconceived notions, which is always awesome.
Yeah, really awesome stuff. But yeah, so that's what we're talking about tonight, musculoskeletal trauma, and we're thanking our sponsor, Sam Medical, for helping us out for that. But before I guess we jump into that stuff, what's going on? What have you guys been up to?
So I got to apply my first care as an EMT just the other day.
Look at you.
So there was a massive injury on during a class. A firearms class, and I got to draw out a Band-Aid and fix that guy's finger.
Was there any arterial bleeding?
I don't think there was any bleeding. I think that
it was just a red mark.
I'm pretty sure it was just fine and didn't need anything. But yeah.
So you had to break open the boo-boo kit?
Yeah. But here's the thing, and this is the reality of it, is that we have a tendency to get so sucked into all the sexy stuff, the tourniquets and the occlusive dressings and the packing gauze. Most of the time, you really need a Band-Aid.
Yeah.
That's what you need. Maybe a different size Band-Aid, but a Band-Aid. So it's good to carry those things.
Yeah. How about you, Jonathan? What you been up to, bud?
Oh man, just keeping my head down, working. Had a couple calls where I've got to do some things I hadn't really got to do, given some drugs I hadn't given before, dealing with some pediatrics. Had a kid that had a seizure that we were transporting 2.5 hours away, and he waited 10 minutes before we got to the hospital and decided to have a seizure. But I did all the things that I needed to do beforehand and kind of was prepared. I figured out what his weight was, calculated my dosages on my medications I was going to give to break any seizure that he might have, had my needle and syringe ready to draw up the meds. And so he got medicine super, super fast because
cool.
I did
Nice.
the legwork early.
Was that like something that you were aware that was likely to happen, or part of his condition was that seizures were likely?
Yeah, unfortunately he was born with an anoxic brain injury, and he had cerebral palsy and a bunch of different things going on. And he'd recently been intubated, and they extubated him, and they wanted to send him to a more specialized facility for pediatrics. And so I was the guy, and so mom's riding in the back, and I slowly watched this kid's heart rate start going up, and I'm like, Mom, is this normal? And she's like, yeah, this is right before he has a seizure. And his seizures were more like absent seizures, and like he doesn't have like the tonic clonic movement where he, you know, convulses uncontrollably. But it was scary because even in that moment, he's not breathing. So he got some medicine to break his seizure, and then he got some ventilatory assistance to get him breathing in the right way, and it all ended up being okay by the time I got there. But it was scary, man. Pediatrics are still, you know, they're scary if you're not ready for it. So, but took care of him.
Yeah.
Had a fella yesterday. I was riding the paramedic response here at home yesterday. I had a guy that found him in between the bathroom and the hallway, and unknown downtime, and he was only responsive to painful stimuli. And what ended up happening was he had an occlusion of his MCA, and so he got flown to a stroke center, and that, you know, unfortunately there's nothing really we can do for that, but just being able to recognize, like we've kind of like harped on, you know, throughout the podcast, being able to recognize and understand that he needs a higher level of care. So
What's MCA?
But yeah, I'm sorry.
What's MCA?
Gosh, you are asking me. And
I'm sorry. I did not mean to stump you.
You're good. You're good.
I was like, there's something.
I don't want to say it incorrectly.
Is it a
yeah.
a heart thing?
No. It's a section of his brain.
Oh, okay. I got you.
Yeah, hang on. I want to make sure I say it correctly on the podcast. So let me.
Yeah.
All right. Middle cerebral artery.
Okay.
Yeah.
Gotcha.
Yeah,
Okay. So it was a stroke, Yeah.
And it was, you know, in that instance, it was very, very difficult to do a stroke assessment because he was only responsive to painful stimuli.
Gotcha.
So, yeah. So he ended up getting flown. But yeah, he had a wonky 12 lead.
Oh,
yeah.
Cool.
So unknown downtime. It's hard to take care of folks like that, but you do the best you can.
Yeah.
Yeah. I had a doozy.
You had a dramatic.
I mean, I guess this is I had one of those instances or one of those calls that it's going to stay with me for probably my whole life career. Like, cause it was the first time I saw cardiac arrest and provided CPR. That was interesting for sure. Like it's all the stuff that you think you're going to see, like actually I can't, let me start from the beginning because this was interesting day for me. First off, it came in as a lift assist.
Oh,
it was a fall in the shower. Oh, okay. So we took off. We're on our way there, and I'm reading through the call notes, and it says like unresponsive. I'm like, okay, well that's not necessarily just a fall assist, like a fall.
I mean, they fell, but
but it says unresponsive.
Yeah,
and then it said caller is 10 minutes out, and like the patient is in the shower, unresponsive, and like that was all it was in. I was like, huh.
I'm confused. How is the caller 10 minutes out?
Yeah, and I was like, this doesn't add up. And then I'm like, well, if we're responding to a fall injury, how do they know she fell?
Oh, they probably have a camera.
Well, I know there was no camera, but like it was. I think she was on the phone with her when she fell and like just stopped responding, so it became unresponsive. So I'm like, all right, this is like a red flag. Mm-hmm. So at that point, I'm like yelling up to the front of the truck. I'm like, hey, paramedic, do you want me to grab anything in particular? Because I didn't want to be like, I'm like, I think I should probably bring in the Lucas for this. Mm-hmm. Like, it's one of those ones like grab all the stuff, put it on the gurney because you don't know what you're going to walk in there for. And it was, no, just bring the blue bag. Okay. So we grabbed the blue bag. Oh, and the heart monitor, of course, because you can't go anywhere without the heart monitor. So those are the two things that come in. We'll grab the gurney, park it in front of the door, get inside, and I was rolling with a paramedic, an AEMT, and myself.
Okay.
And the AEMT was the first one in the door. He walks in. The caller was like, "Oh, she's down, like she's in the shower or whatever." So at this point, I'm like, "Oh, we're gonna have to help, some lady up out of the shower." So he goes into the bedroom. I'm following right behind him. I got the bag, and all of a sudden I just see him turn right around and look at me and go, "We need fire." And I'm like, "What?" He goes, "Yep, we like," and he starts miming to me like cardiac arrest. And I'm like, "So we need to do CPR?" He goes, yeah, but we need backup. So I turn around, I go, "We need backup?" And then like he's going over assessing her, and she's like collapsed halfway in the shower, and like she was down. Like and it was a shortish amount of time, I guess, because there was a call. I don't think anybody was actually there to witness it, but she was down relatively recently. And he tries getting over, and like he can't get into her because it's a tiny little shower stall. So I had to help get completely dead weight. And she was a big girl. She's obese and nude
wet
in the shower and wet. And it was like, how do we? And so I had to get behind and like help move a body. And I was like, but here's the thing. And I know like it sounds like a lot going on in my head. I was like, okay, this is just what we do. Mm-hmm. And it was so weird because it kind of just went into what I thought we should start doing. So we moved her out, got her into the bedroom, got her laid out flat, assessed. And I got like, he was like, "Hey, we need CPR." Okay. I got on the chest, felt the crunch for the first time. I was like, and the only thing that went through my head was, "Oh, so that's real." And I just kept going at it.
Yes, it is.
Yeah, I was like, I thought it was bullshit. I'm not going to lie. I thought everyone was like, "Oh, maybe it happens every now and then." And as soon as I did it, like, it was like cracking all the knuckles at once. Mm-hmm. I was like, "Oh, that's there." And so I started doing CPR or chest compressions, I should say. Well, and he started working on airway. And at that point, everybody started coming in. We had the chief from our department coming in. We had the chief from a fire department coming in. All the fire department. We had 2 police officers. All started I guess this is what happens during codes, right? And I was like, "Wow, there's a lot of people here now." And I'm just on the chest, just, "Hey, I got one job. I'm doing this." And then we, there was a lot of stuff happening at that point. Obviously, the paramedics jumping in, starting to do IV access. Getting epinephrine on board, and that was the first time I got to see some of that stuff really get used.
That's cool.
Wow, does that work? Because long story short, we did this. We got good CPR going. Everything we've talked about on the podcast for like, well, let's just say the triangle of life was not doable. Because it's not like it's a spacing issue. Yeah. Like all of a sudden you're in a space that doesn't allow for people to be in it. And I'm like, okay, right. So this is where it's probably a better term to use pit crew CPR, because we were like jumping in and out and like moving around the patient and doing what we had to do. So I went from chest and then swapped out and took a quick break. We were working on her for, I don't know, probably 5-10 minutes. And got some epinephrine on board. She responded well to that, got a pulse back.
Nice.
And that's where she was when we transported, got her into the truck, and they kept giving her epinephrine on the way, and she would kind of go between pulseless electrical activity and having a pulse back and forth. And every time they gave her epi, she would get a pulse back and then kind of fall back into PEA. And then they'd give her more epi. And so I was like, wow, that stuff works. Like, or I guess in some patients. So I think it wound up being like 3 or 4 rounds of epi on the way to the hospital, and the whole 9. Like we're like back onto the chest. Like I had to give chest compressions.
How did that go?
What?
While rolling?
Oh my god! I was just gonna say, it's like surfing. So I'm standing there next to the gurney. I have my hand up on the grab bar above, and I'm doing 1-hand compressions on the patient, and I'm like, well, it's working. It's not the best, but as soon as we stopped at the hospital, I got to switch back to 2-handed.
So what about the gurney going into the hospital? Like giving compressions while you're rolling with the gurney? Oh,
so while we were rolling with the gurney, the fire chief, I think it was a fire chief, he was driving the ambulance, because of the 3 of the EMTA, myself, and the paramedic were in the back,
right,
working the patient. When we got there, he helped take the gurney out. We were bringing her out, and he switched with me because I couldn't give compressions coming out of the ambulance. So he jumped on to the edge of the gurney.
That's what I was wondering.
Not on top, but I also learned that you can ride the rail on the side of the gurney, just stand on the rail and then stand up high enough if it's at the right height to give compressions. So he jumped on, stepped up onto it, and then we rolled him in while I was bagging to bring her to the critical care area where they kind of turned that into a resuscitation bay. Mm-hmm. It was nuts. I did so many things that day. I'm like, I'd never done this before, but the thing was like, it went really fluid. We had really good communication. Our chief was there. He was coaching us through the whole thing. It was like, oh, I know all of this. Like we talked about all this stuff on the podcast, the whole process of having a coach who's being there, making sure everyone's doing the right thing, filling any gaps, making sure that everyone's supported. Everyone's, not getting fatigued or hurt. The hardest part about the whole thing, honestly, was just moving the patient.
Yeah, I believe it.
Like out of the bathroom, up over a bed because there wasn't enough space, out the door. That was the biggest logistical challenge. Everything else went really smooth in terms of like, I got to see a supraglottic airway for the first time. Eye gels are awesome. It worked really well. Worked way better than me having to hold my hand.
Oh yeah, for sure.
In a C-clamp position while providing air.
Right.
You're getting way, way more efficient ventilation that way.
Yeah, it was, I mean, you could tell that it moves every now and then, like, cause you'd hear some air escaping if she was moving around or we were moving, but it was way more secure than having to have two hands on there doing like holding it in place with a bag valve mask.
Cool.
Right.
Yeah.
Yeah.
You need to record that. I mean, we're recording this here, but
we just did.
But like, you should definitely for yourself, just for yourself, make sure that you get that written down somewhere so you have it. Because the reality is, in 6 months, you're not gonna.
Oh, I took notes. I have.
Awesome.
I keep a log.
Knowing you, I kind of figured as much, but.
Well, I've realized in my old age that I forget things more.
Yeah.
So I've been keeping a log of every day that I volunteer. I don't know if that will stay forever, but I just like being that I'm not in such a high volume right now. Every day that I go volunteer, if I go on a call, I come back and I write down like the demographic and the big things that happened or whatever. Yeah. It's like just a notebook type thing. But
awesome.
I want to make sure that I don't forget that one.
No, exactly. That's what I'm saying. And remembering all those details and bringing it back to mind.
Yeah, it was. When I got done with the whole thing, I just looked around like, all right, well, that did what it's supposed to do. like the CPR worked. Like I was like, holy cow! Like she was dead. Like she was completely like cyanotic and not breathing. I think what had happened was she had a history of CHF and trouble breathing and fatigue in the days leading up to it. And I think she collapsed in the shower, and I'm betting that she wasn't in cardiac arrest right away. I'm betting it's like an asphyxiation from like body positioning.
Oh yeah.
And that probably took a while for her to go into cardiac arrest, probably happening very close to the time that when we got there. And I think that's probably why we got good results. And then, she got her pulse back. And when we left the hospital, she had a pulse. And it was going. Here's the other weird thing about this. I'm kind of like, I'm curious. Like I would love to reach out to like the EMS team to be like, hey, did you guys hear anything? Because sometimes you hear from the hospital, like what happens to a patient and all that stuff. But then part of me doesn't want to because I don't want to know like what like if it was bad, like if she passed away, I don't really want to know. But it's almost like it's not important to the job.
No, the important part is that when you left, when you did everything you could, your team, to make sure that the hospital had the best chance to have a good outcome.
And that's how I'm looking at it. Yeah. Like
100%.
I'm looking at the event to make sure like, hey, did we do like trying to gain like, AAR it in my head on the way back. And we did it that day. We did a hot wash type thing. And it was good. Like, we did everything we could do. We communicated. There were some minor missteps and some things that were like, okay, well, if we did that different, that would probably be a bit better. But it was good. Yeah. I was really impressed. Like just seeing all the different people there all falling into the roles. I was like, oh man,
that's awesome.
This is super cool. I'm like, I guess I kind of really, got to feel like this has come to fruition.
Yeah.
Like being part of EMS.
It's a capstone from student to EMT.
Yeah, provider, I guess.
Sweet.
Yeah, it's definitely a big moment the first time you work your first cardiac arrest. Yeah, it sounds like everything went as well as it could have been expected.
Yeah, I think so. And I know I don't want to get jaded because I know for the vast majority they don't wind up that way.
It is a rare occurrence to get somebody there and the long-term outcome be positive. But that, like you said, it's kind of not the point, right? As far as us in the heat of that moment, we're doing all the things that we can do to give that person the best chance.
Mm-hmm.
And to some level, when we pass along care, it's just kind of up to how the cards are dealt that day as to what ends up occurring for somebody. But as long as we're out there doing the best we can do, that's all we can do.
Yeah.
Yep.
It was very eye-opening. And I don't think I'll ever forget that one. For sure.
I don't think you will either.
Yeah. But yeah, so I mean, we're experiencing all types of things. I'm super excited to be a part of this.
And if you're a student, like, first of all, you should be volunteering at some EMS somewhere near you.
Oh, for sure.
Like, it is going to help you so much when it comes to the actual, learning and absorbing the information and getting it rock solid in your brain. And you should be doing that. That way you're seeing these things and experiencing these things. I think it's hugely, it can't be emphasized enough.
Mm-hmm. So yeah, we're all experiencing new stuff. It's great.
Yeah.
I love going on this journey with you guys. This is really fun.
Mm-hmm.
I'll probably in 6 months be like, this is the worst. I had a bad call. I'm covered in shit.
No, he's gonna be like, I tore my calf again.
Yeah.
Because I was skiing,
or I tripped getting out of the ambulance and I hurt my knee. Like there's gonna be those days too.
There's one truck that
there are those days.
Yeah. There's that
for sure.
There's that one truck
days.
that our one service runs that I swear to God, the one day I thought I blew my knee out getting out of it, just because it was so much taller than I was expecting it to be, and I go to step out of it, and it's like, so. Anyway.
Yeah. So lots of things going on.
Yes.
But this week, let's bring it home. Let's bring it back around because we got an agenda. We've got shit we got to do, Max.
We do.
No.
We can't just chat we could, but
I mean, it'd probably be a fun podcast too.
It would.
It's just talking about things that we're doing.
Mm-hmm.
But that's kind of what we do, honestly.
It is.
It's like the first 30 minutes of every
at
episode.
least, or hour.
Sorry, everybody. Now you could just skip to 30 minutes in and get to the meat and potatoes. But we're talking about musculoskeletal injuries.
Yeah, and what is your medical term of the week?
Oh, you just want me to jump right in?
We're jumping right in.
Just like stop talking, Mike. Get to the point. Okay, so the medical term of this week is the 6 P's of musculoskeletal injury.
I don't see any P's in that word.
The 6 P's of musculoskeletal? Yeah, there's no P's in musculoskeletal. There's some M's.
Yeah.
Well, some vowels. We can buy a vowel. Where's Vanna White when you need her?
Exactly.
No, it's the 6 P's are. I mean, if you it's another addition to the alphabet soup of EMS.
Swear,
we get 6 more P's though.
Yeah.
I mean, if you land on a big number when you spin the wheel. Like you could really rack those up.
You could.
There's 6 P's. Oh shit! I just won $6,000. Anyway, that's a Wheel of Fortune reference, by the way, for all you youngins out there. I don't know. Do they even show Wheel of Fortune anymore?
I don't know.
I don't think it's the original host anymore.
No, Pat Sager's gone. It was the guy from American Idol when it first started.
Both Jeopardy. We've aged out of both Jeopardy and Wheel of Fortune.
Trebek unfortunately passed away, but
I know. I'm just saying, but like the hosts have changed.
Yes.
We can't even
Price
hold
is
on
Right.
to that.
Price is Right. Bob Barker's gone.
Well, that wasn't it Drew Carey for a while.
Mm-hmm.
Is he still doing that?
I don't know. I don't watch daytime TV.
Me neither. Anyway, so the 6 P's of musculoskeletal injury. Sorry, ADD break. The 6 P's are a classic set of signs used to assess limb-threatening injuries and the presence of, this is a big one, this is the key term, acute compartment syndrome. a dangerous condition where pressure builds up inside a muscle compartment and begins to cut off circulation and nerve function. So we're going to touch real quick before we get into the P's on compartment syndrome, because you have to understand why it's super important.
Yes.
Before we define it, Jonathan, have you run into compartment syndrome in your career?
Yes. Not necessarily in a musculoskeletal, like a fall with a broken bone. But early in my career, I transported a guy to a higher level of care. He had been involved in some sort of illicit activity, and he got stabbed in the forearm.
Oh.
And so, they brought him to the hospital. They're dealing with that. And then at some point, he started down the path of compartment syndrome, super, super swollen, super red and inflamed. And I mean, like, there was not an inch of give in that skin, like, at all in his forearm. So he needed to go have that dealt with.
That's interesting.
At a higher level of care. Yeah, at a trauma center. So, and our local hospital's not a trauma center. They're more into stabilizing care. And then they usually ship things out. So I was part of the transport team that took him to that higher level of care.
Because what I found most interesting about compartment syndrome was learning about how it can be caused by things that I didn't necessarily think caused compartment syndrome. Because originally I had learned about it through like tourniquet usage, in terms of, you're going to use a tourniquet, you're going to cut off blood flow to a limb. It's like compartment syndrome. It stops perfusion. They can only do it for a couple hours, and then they lose the limb. Their limb falls off randomly. No, that's not the case. You have multiple hours that you can deal with being tourniqueted, and the same thing with compartment syndrome as well, because essentially it's the same thing. But instead it's your own body's functions occluding blood flow to the rest of your limb. It can be caused by fractures, which is honestly the most, or according to the textbook and the things that we learned from, is the most common form of getting compartment syndrome, or the most common cause of compartment syndrome. But it can happen from like crush injuries. It can even happen from interventions that have been provided that are just too aggressive.
Right.
So, like when Max applies bandages, he's gonna apply bandages with as much force.
There's not going to be any blood coming out. It's all staying in, all of it.
Max likes to gorilla grip everything. He's got these big man hands that just make me jealous. But like bandages that are too tight. Or I should say dressings are what touches the wound. Bandages are what holds the dressing to the wound. So bandages that are too tight can cause, basically act as a tourniquet, right? That can be too tight.
Right.
Casts can be too tight because casts are a rigid thing. And if your body swells underneath the cast, it swells against the cast. The cast acts as a thing that'll, basically be like a big tourniquet. Rings can cause it. Or other pieces of accoutrement that occlude blood flow if your body swells under it. Splints can cause compartment syndrome too. So like those things that we provide, if not applied properly, can then cause further damage. Now, what is compartment syndrome? It's swelling. So the swelling grows so much like internally that it creates so much pressure inside that your skin like can only contain so much pressure. And instead of bursting, because that would be crazy.
It's actually a good thing.
It would actually
that would be bad.
Yeah, well, technically that's what the hospital does when you get there to stop.
But you show up and like someone's leg just goes
boom.
Pop.
Yeah, that would make EMS a lot different. But so compartment syndrome is when it swells so much from the inside and it pushes up against your skin and your fascia that do not expand any further, and it creates like an internal tourniquet, for lack of a better term, in the different compartments of your muscles.
Right.
So essentially that stops blood flow. It stops perfusion and creates cell damage. And that cell damage, guess what? Then causes more inflammation because it's releasing all these things that are then, causing the body to react. So it's kind of one of those things.
Ischemic injury.
Yeah. those things that we've talked about before that go haywire, things like anaphylaxis or sepsis, like overreactions of your body's actual, defense mechanisms, is kind of in that same vein, where the things that your body's supposed to be doing, it's doing them so much that it's causing an overreaction, too big of a problem. So that's essentially what compartment syndrome is, and that's really bad because if it lasts more than a couple of hours, then you can lose the limb. Like there's too much damage,
tissue death. You have nerve damage.
Exactly, the nerve damage is a big one too.
Yeah. So
to help assess this, to look for the signs of acute compartment syndrome or just severe limb injuries, somebody along the line came up with the 6 Ps because there are no other letters in the alphabet apparently, and Ps are all we got today.
Say, hey, we're not using these Ps for anything else, right? Okay, yeah, let's put them here.
From the Scrabble tile bag of EMS, they took a big handful of tiles out, and there was just a bunch of Ps in their hand. They're like, you know what, we'll make do.
Yeah, we're gonna make this work.
So we got 6 of them, and they're all, here's the kind of thing to keep in mind. They're all part of the CMS or PMS assessment.
Yes.
And what is PMS?
Pulse, sensory, and motor function.
Right. So anything that we're doing with musculoskeletal injuries, we want to keep CMS, or CMS is circulation and motor sensation, or pulse motor sensation. You could use them interchangeably.
Yes.
I've seen them used interchangeably in even the textbook. So you'll hear us in this podcast probably use both.
Right.
Either PMS or CMS. I think CMS is more the modern, I think they're moving more towards CMS.
It's probably the more appropriate way to phrase it now, right? Because we're looking at all aspects of circulation and not just pulses.
Yep.
Right. But when I learned in EMT school, it was PMS.
Yeah. Right. Yeah. And I mean, this is probably very shallow, but I would assume they're probably moving away from PMS as an acronym because of premenstrual cycle as well.
I would assume
or premenstrual syndrome. Yeah, sorry. Cycle is a C. But that is a term, a well-defined one.
Yeah.
That it's like, oh, when you say that term, even in a medical context, it's very recognizable. So CMS is more, I guess, probably unique. I don't know, but they use both. So, and I've gotten used to kind of using both of them. But the 6 Ps are part of that CMS story.
Right.
The first one is pain. So, musculoskeletal injury is probably going to be painful.
Yeah.
Just in general, they're always. It seems to be a hallmark. If it's not painful, that's probably more
unique. Even worse.
Yeah. So pain or tenderness is the first thing you're looking for. And really change as well too. Especially if you're doing things or if it's getting worse over time, that can be an indicator that that it's progressing.
Right.
Like if you have compartment syndrome, that it's progressing because it can get more painful. And then that also kind of falls into, well, how are they perfusing, right? Like as we know, the whole story of, the life in general is perfusion. So pallor is the second P. Pallor being the skin tone, skin color. Are they perfusing well? Is their skin pale? Are they getting good capillary refill? That's the pallor side of it. And if it's getting less over time, then that's another indicator that things are going bad, or if it's bad when they get the injury. The third P is a P that I had never heard of before.
Same here.
Although it makes, I guess the term pins and needles has a P in it.
It does. They could just have used that.
They could have just used pins and needles, but instead they use paresthesia.
Right.
Which I guess is like a medical term. But paresthesia is the third P, and it means that sensation of the pins and needles, which is an indicator of some sort of nerve, like pain or nerve interruption, I guess. Impingement. Damage. Like those are things that okay, that's not the sensation that you should be having. Essentially, I heard pins and needles once described to me as static. Where it's basically like when you have a bad reception on a TV antenna. By the way, for all those youngins out there, a TV antenna is a thing that used to put on the top of your house that would receive signals from the air, like a car antenna. But on your television would be static. Actually, I guess you could hear static on a radio too. I don't know. Do they even have radios anymore?
I don't know. I know people that do radio classes, but I don't know if they have radios or not.
But radios are, like it's that signal interruption stuff. Yeah. It's static. It's like white noise, and that's what the signaling in your nerves are doing. It's kind of like, we don't know what this means, so it interprets as pins and needles. Anyway, so paresthesia is the third P. The fourth P is pulses, which is, the big thing that we're checking for. We're always checking for PMS or CMS, the first letter being circulation or pulse, making sure that they have a pulse distal from the injury in their limb. And paralysis is the fifth P.
That would be like the next step after the pins and needle thing.
Yeah, I would say paralysis is probably a pretty big indicator of a bad problem.
Yes.
That would be something that's like, okay, they're either having some sort of nerve damage, or it could be that the pain is so high that they literally cannot move their limb. Those are both things that are like, that's a big red flag. And then the last P is probably the one that's most indicative of the process of ACS, or acute compartment syndrome, and that is pressure.
Right.
Pressure being like, if they feel like, I just feel like there's so much pressure in my arm where that thing is, that's a big,
that's not a good sign.
That's that in and of itself is defining the precursor to compartment syndrome. Like, I feel like my skin is going to burst. Okay. Well, that's not good. So yeah, those are the 6 P's: pain, pallor, paresthesia, pulses, paralysis, and pressure.
Say that 5 times
Do
fast.
not quiz me on it, because I will not remember them. But those are the things that you should be looking for. And, the way I look at it is like, those are the things that I look for as I'm looking for, like, hey, how does your arm feel? Well, if they say it has pins and needles, I know that that's on the list of 6. If they say, I have pressure in my arm, hey, I know that one. That's a big red flag in the list of 6. So I use it as a reference list in my head of, if I see these things in my assessment, then I know I check those off the mental box to go, those are red flags to know that could mean like, hey, we need to hurry this up, or pay closer attention to make sure it's not trending any worse. But yeah, those are the big ones. And unfortunately, like we've learned with a lot of things, on the EMT side, there's not a lot that we can do to directly affect compartment syndrome. The big one being recognition. Like,
making sure that the next level of care knows what's going on.
And like this one, I think, is also a big one too for maybe even refusals. Because like, I assume there's probably going to be like people out there who like, I broke an arm. Well, I don't want to go on the ambulance. I don't want to go to the hospital. I'll go to my doctor, even though you should go to a hospital. But they may have the tendency to go, well, this isn't that bad. Well, even, a break somewhere, in the small bones, the hands, the feet, whatever, that could still lead to compartment syndrome. Sure. And if you're seeing those symptoms, you should really advocate for those patients to, hey, let's go get this checked out. This could be something very much bad,
Something with it, Mike, is that compartment syndrome doesn't immediately present itself.
Exactly, yeah.
Right. It may happen over a few hours after the injury. So you may think, I'll get checked out later, either through my primary care, or I'll take myself to the emergency room. But, within a few hours, it could definitely start to form.
Yeah. Right. And it's, one of those things that you have to inform them. You have to let them know that this could be a huge implication. You could lose a limb. You lose your life if you do not get this addressed and come, like, you can come with us. We're the fastest way to get you the care you need.
Yep.
But ultimately the choice is theirs, but you can only do so much. We could do things like loosen, like take off of rings, all the things that we said, those can cause, constriction, really tight fitting, watches or bangles. Bangles, is that what like a wrist thing is?
Yes.
Like a
A bracelet.
A bracelet. That's what I'm thinking of. I'm having trouble thinking of words. Maybe I'm having a
Are you having a moment there, sir?
transient ischemic attack.
Yeah.
No. But I'm just old.
Well, yeah.
Like with that, with those things that we might want to, loosen or take off, shoes.
Oh yeah.
Shoes are a big one.
Yeah, they don't expand much.
No,
they do not.
That's actually I did not read that. That's a really good idea. Like, especially like ankle injuries, foot injuries, those are things that are going to have musculoskeletal injuries.
If anything else, I mean, just cut the laces.
Yeah, I mean, allow for expansion.
There's a lot of room in the actual shoe itself usually to expand.
Yeah.
But just get your X shears out and cut those laces right off.
Yeah, X shears, great shears. The gloves too, I assume, like leather gloves.
Yeah.
If OJ had his gloves on before his hands swelled from the lack of arthritis medication.
Mm-hmm.
Anyway, from the 90s.
Like, who?
Who's that guy? That guy from the Police Academy movies.
Yeah, exactly.
The white Bronco. Anyway, like things being on too tight that we could take them off before swelling starts, that can help the process or help, keep it from getting really bad. And then really the big thing that we can provide is splinting, which may not stop compartment syndrome from happening, but it'll certainly keep it from getting worse quicker, because we're stabilizing the injury. We're making sure that it is not causing more harm. And hopefully that would prevent, maybe enough damage in the first place of the compartment syndrome happening. But the big thing that we can do is help stabilize, and that'll help reduce pain. It'll help keep it less, and from getting worse.
And your CMS and PMS, whichever you refer to, is an intricate part of the splinting process.
Yes, 100%. And then the last point in there is there essentially this is from swelling. If there are strategies to reduce swelling, those can be incorporated. But the big one that they kind of told us about was just the body positioning. So if you have a limb that can be brought up to or above heart level, that can help reduce swelling. However, I would say that one's probably the hardest to implement just because of the nature of musculoskeletal injuries. It's really tough to have somebody who breaks their arm, bring their arm up over their heart. Yeah. Or their leg.
Right.
But when you're laying them down, that can come into play, keeping their...
It might be one of those few uses where you do use that lower level of the stretcher to get their leg higher than their heart.
It could, yep.
Trendelenburg,
Trendelenburg position. But yeah, those are the things that we can do. Ultimately, to try and get these patients to higher levels of care, where they can hopefully reduce some of that swelling, by means that are not what I read about today, because apparently the only definitive treatment for a acute compartment syndrome is a fasciotomy.
Yeah,
which
we've covered before.
We talked about last week on burns. Where man, a fasciotomy sounds terrible. They cut down into the layers of the skin to release pressure.
Another plug for the pit if you want to know what that looks like.
Yeah, they've done a fasciotomy on the pit. Actually, we have not figured out yet if it was a fasciotomy or an escharotomy. That was because they did it for a burn, and I don't know.
Sure.
It kind of they're very similar. One just doesn't go as deep. So, let us know if you know what's going on. If you're watching the pit, if you're like, no, you idiots, it's obviously an escharotomy because he's not only going through the dermal layer. I don't know. Like this, we're monkeys just reciting from a textbook.
Or if you're a provider that's done it multiple times, we would love to hear from you.
That would be cool. If somebody who's an ER doc is like, you know what, I'm just going to listen to these guys learning the beginning steps of this world that I know. Come talk to us.
Yeah, exactly.
Let us know how we're doing.
Exactly.
Are we getting it right? I'm hoping for an 80% solution.
Hey, 70 to 80%, somewhere in there.
Passing grade.
Golden.
Passing grade on an NREMT
exactly.
exam. Which we will be talking about how to pass some NREMT exams later in Jonathan's segment. So stay tuned.
Yes.
We're now incorporating some test prep questions into every episode.
Exactly. And breaking down the answers, what to look for, why not to look for, what answers you can rule out. So stay tuned.
Yes. At the end of every episode. You can fast forward to it if you want.
Exactly.
That's where you get to hear Jonathan's sweet, sultry Southern voice.
Exactly.
He's so modest. Well, that's the medical term of the week, is the 6 Ps. And I guess that kind of leads us into our main chapter this week, which is musculoskeletal trauma.
Yes.
And, all of the things associated with it. It's a big one. There's a
lot of information in it.
Yeah. I mean, we'll try and get through. Let's not belabor it. But there's so much. And we encourage you guys to go out and find this stuff. If you really wanted to get this down to, I would say the most, the most distilled, I would bet, and you guys feel free to disagree with me. Compartment syndrome, understanding that, CMS, splinting, and the different forms of splinting are probably the big parts of this, right?
Yeah, I mean, when you break it down to what we can affect, that's basically it, and what we can do, that's basically it. And honestly, it's not like we can deal with compartment syndrome, but like you said, we have to be able to identify it if possible. That way, the advanced care knows what they're dealing with.
Mm-hmm.
So yeah, I mean, I think that's your basic breakdown of what you need to know about it. And it's good to know basic anatomy.
Yeah.
Yeah.
Yeah. I would say the anatomy is because there's a lot of parts of anatomy, right? And that's kind of the starting point where they brought us through this stuff is the skeletal system and the different parts of bones. And there's a lot. There's there's different parts of the skeletal system. There's a axial skeletal system, which is your head, neck, and spine. And then there's the appendicular system, which is your appendages. And it's is anybody really using that terminology? I have not come across it.
No, I don't
Usually,
think so.
If they're talking about a bone, I think the most important thing to know is your major bone system.
Yes.
So your radius, your ulna, humerus, femur, tibia, fibula, your long bones, the skull, the mandible, the maxilla, maxilla.
Yeah, that's your upper,
the top of your see, I'm not great at remembering all the bone names off the top of my head, but shoulder blade, your scapula, right? Or even using common terms, the left index finger.
Well, or for spinal injuries, knowing the regions so you can tell them, okay, he has some kind of something going either in the cervix area or the lumbar region, knowing the basic areas so that you can tell the next level of care what you found.
Yeah. And we'll get into spines a lot more we have a head, neck, and spine trauma episode that'll be coming up. One of the trauma block episodes. Yes. But there's a lot to go into there. But I think it's important to know that you will treat things differently depending on the different parts of the body, but the principles are the same. We're going to immobilize, and we'll talk about what the purposes of splinting are, but knowing the structure, knowing the things that we're talking about are important. Knowing what bones do and how they act. That was something that was important to kind of wrap our heads around in terms of they have different parts to them, right? We all know about bone marrow. Bone marrow's inside the bone. It creates produces blood cells. There's spongy parts of the bone. There's the periosteum, which is the white coating on the outside of the bone. But do we really need to know that for what we're doing?
No. I mean, I think the main thing you're doing as your role as an EMT, if you can, is identifying if they have a fracture, whatever it winds up being, where it's located, and being able to maybe identify which bone has the fracture, and then doing a definitive care that's appropriate for it.
Now, I would say it's important to understand the different, what those pieces are, but... And this isn't me downplaying that you shouldn't know anatomy. You should. and what those things are. But to know what's the purpose of learning all those things is the understanding that there's different parts, how they play together, how they have different reactions, and if you see different things, they can mean different stuff. And one of those being different ages could have different types of breaks and different performance of their bones. Yep. So that's one of the things that stood out to me was okay, the difference between adults and kids is often seen in the fact that kids have weaker their bones are a bit weaker because they have growth plates, and their bones are still growing. So growth plates are weaker than adult ligaments.
Right.
And for kids, when they get injuries to those bones, they tend to have fractures instead of ligament injuries because the bones are easier to break at that age. And that's just why. You understand oh, well, that kid didn't get a more serious injury than somebody else. It's just that they have a more susceptible anatomy to breakage, right? So understanding those things helps with knowing what treatments we need to do. So if a kid falls and lands on their arm, okay, well, let's be a little bit more cautious and make sure that they don't have any breaks, you know, which we would do for anybody.
Yeah, and then the opposite side of that being with senior citizens, where there's certain areas that can be devastating for them, and that you're going to see more frequent breaks in. In their hips and so those are things that you have that's good to know the trends and know what to look for and how to treat it.
Young kids, older adults, way more susceptible to bone problems and breakage. But I think the most important story about bone is actually the kind of coolest thing about it. And I've known this, we learned this as kids, right? And when we have somebody who breaks their arm.
Yeah, how does it heal itself?
Yeah,
it's crazy.
They just put a cast on it, right? And they leave it alone for 6 to 8 weeks, and all of a sudden they now have a magic arm that is fixed.
It really is. It's one of those things. There's a couple things the body does that's pretty miraculous. Being able to just fix bones as long as you leave it alone. Being able to insert an organ like the liver healing itself and regrowing. I mean, it's kind of crazy that the body can do that.
Actually, you know what I have a much higher appreciation for now that I've done, we've done this EMS stuff? Clotting.
Yeah.
Like the fact that the body can plug its own holes, in emergency situations is that's pretty awesome.
It is.
And it can do that pretty well. Actually clotting and vasoconstriction, those two things, people can get amputated arms and still live without a tourniquet on them. They may not live forever, but those two things working together can do miraculous stuff. It's incredible to hear some of those
really
stories.
Is.
But the bone has that same type of magical properties where it's okay, if you put it in the right place and you just leave it the hell alone, it will repair itself. Now, granted, there may be some things we have to do as well on the medical side. We don't do it in terms of setting it in the right place, but the process that we're a part of on the EMS, the pre-hospital side, is pretty integral to that healing process down the line, because we're making sure it doesn't get any worse.
Exactly.
In this moment, right?
We're giving it the best chance for the greater care to make sure that it fixes itself properly.
Yeah. So this is where the proper alignment and especially with splinting, the immobilization come into play, where we're making sure that when somebody experiences that injury, it's not getting worse, it's not tearing, it's not grinding against each other, it's not causing additional damage, and that we're we typically do it for CMS reasons, alignment of a limb, and we'll talk about that too. But that's important for the immediate right now type stuff. But having that proper alignment, making sure it's not getting any worse, is pretty integral for when they set it and they set that bone. They align those bones together where they need to be for healing purposes. In the long run, and the less craggy, shattering breakage that happens, the better those things are going to fit back together.
And if you've never seen a break on like an X-ray, they're generally not this clean thing. They usually have some very sharp edges. So those sharp edges not doing more damage to the muscle, to potentially to an artery, is huge.
Yeah. Actually, you know what's really crazy when you see those X-rays and you see all the pins and stuff they have to put, like they have to like reconstruct somebody's bones and stuff. Yeah, that's what we're talking about here. Is like those types of like some of those are going to be so bad that you may not be able to splint them. Like you're not splinting the bone into a place, but what you're doing is you're making sure that limb isn't like wiggling about and causing all these little bone shards to start causing extra problems, right? Like the less that thing moves, the better.
So when I was 10, my dad had broken his arm twice previously, his elbow, and for a third time he broke his elbow, and I helped my mom like get him set up so we could go to the hospital. And afterwards, he had pins all through his arm. Like he couldn't straighten his arm out all the way. He kind of had it like a little bit of an angle. But I remember to this day the feeling of like holding his wrist and feeling that bone moving in it. That was just weird. Weird.
Yeah. Yeah. I'm lucky that I've never experienced a break. Like a bone break. Well,
you broke your hand. Everyone's broken their hand.
I've probably broken a hand. I have had an avulsion fracture, which is a type of, well, it's really just a really bad sprain. It's not really so an avulsion fracture is when you pull your ligament so hard that it pulls a chip of bone off of the bone. So it's a fracture because you actually have bone that breaks, but it's really more of they treat it like a bad sprain.
Yep.
I couldn't walk for a while. By the way, don't attempt to do a spinning back kick in karate if you unless you know how to do a spinning back kick in karate.
Don't punch things that are hard because they punch you back. It's a very quick lesson in physics.
Yeah, like Sir Isaac Newton figured that one out.
Yeah.
For every action, there's an equal but opposite reaction. But yeah, so we're talking about obviously bones have that ability to heal, which is awesome. But sometimes that's not the case.
Right.
The body heals a lot of different things, but joints are one of those things that also is super.
It's a complex form. I mean, you're dealing with two bones coming together, the things that have to hold the bones together, the things that hold the muscles to the bones in the same general area. You have the plates that, the two bones are moving on. Like it is a complicated structure.
Yeah. Like everything's moving, right?
Yeah.
And then you have all these things that connect it all together. So like we're in the anatomy section, like there's key things you need to understand in terms of, okay, we know what bones are. We know what muscles are. There's different types of muscles, but we're talking mainly about skeletal muscles, like the big ones, like the ones that, like the biceps, the triceps, the gastrocnemius muscles. I'll talk about my gastrocnemius muscle in a minute, but it's the only reason I even know what that muscle is. We're talking like the muscles, the tendons. Tendons are the things that connect those muscles to the bone.
Yes.
They allow your body to actually have motion because the muscles contract and they pull the bones in places, right? The ligaments, which are the things that connect the bones to the bones. It's the hinges, right?
Yeah.
Like it's the things that allow the structure to stay all together. Otherwise, all the bones would just fall into a pile, like surrounded by meat. So those tendons are really important, and the ligaments. And then in between those bones, you need some sort of lubrication or things that help them slide next to each other. So you got the cartilage.
You don't want to lose that.
No, that's osteoporosis. No, that's osteoarthritis is losing the
or just
arthritis
abuse throughout the years. Yes.
Oh, arthritis is the worst. Don't get old, kids.
Yeah.
You're gonna get it either in your knees, your hips. I get bad arthritis in my hips.
I have arthritis all through my lumbar.
Your spine.
Yeah.
Wow.
Yep.
That's rough.
It's good stuff.
I have a slip disc. Oh, we could just talk about a whole episode where we just talk about our ailments.
Oh, I've got a list of bashes and body injuries that is a mile long.
We can
Well,
just
you guys are in EMS now, so
Oh,
that's
yeah.
only going to get longer.
yeah.
Moving 700-pound refrigerators.
I would say that like caffeine addiction, I'm going to blame on EMS, but that existed long before
Yes, it
I got
did.
into EMS.
Yes, it did. As I drink some caffeine.
But yeah, so like all those things are important, but like you want to know the parts of them and how they come together so that you can help, splint things and stabilize stuff as part of injuries.
If you come upon a scene and someone's arm is facing the wrong way or bending the wrong way, you want to be able to know what is associated with that injury and how to deal with it.
Yeah. Okay, so we've gotten through some of the basics, right?
Yes.
What's next? Like, in the grand scheme of things, people get injured, right? What causes the injuries?
Mechanisms of injury.
Yeah, like that's one of the
Yep.
key things that we learned as trauma in general,
Yep.
right? Like if you have your mechanism of disease, you're on the medical side,
Mm-hmm.
the mechanism of injury, or not mechanism, method of disease. What on the medical side? What am I thinking of?
The pathophysiology.
Yeah. Well, anyway, like the MOD, I learned it as MOD a long time ago. The mechanism of disease versus the mechanism of injury, right?
Mm-hmm.
Right.
So on the trauma side, we're identifying that mechanism of injury. We're figuring out how somebody got injured.
That's your it's your part of your primary assessment. Like you're looking to see what is going on, what may have happened, what may have caused it, and that's going to determine how you do your care. You've got things like direct force, which is a bone, a blow directly to a bone.
Yeah, something hitting the bone, like a hammer hitting the bone.
You have indirect force, energy transmitted through limb, like from a fall.
Mm-hmm.
And then you've got twisting force, rotational injuries, which is very common in sports and can do a lot of damage.
Yeah. You get because the twisting stuff not only can damage the bone, but it could also influence all of those those joints.
Yep.
Because joints only most of them only work in one direction. As soon as you twist them, they don't like that. My knee especially does not.
No.
It's not like being rotated in different ways, but knowing how that injury comes to fruition helps us understand where the injuries are.
Right, because you could have had that twisting force. They may not have a broken bone. They may just have injuries to all the connective tissues in the joint. So knowing how to deal with that versus knowing how to deal with a break in your humerus as a result, there's two very different things. And again, this is all part of your primary assessment. You're rolling up on scene. What are you seeing?
Well, so that would be the secondary assessment, because primary assessment is life threats, but the secondary assessment and the full trauma assessment would be part of that.
Yeah.
Like, hey, we're gonna make sure we need to find out all the stuff.
Yeah.
Right. Go ahead.
So
Jonathan.
your mechanism also can be an indicator of the level of care that you're going to be providing, right? A fall off a step ladder may not be as severe as a fall off of an extension ladder at full extension,
Right.
Yep.
right? So that can tell us a lot about our mechanism and our level of care that we need to provide.
Yeah.
Yep.
Or something as simple as like, well, how did you hurt yourself? Well, I hurt myself running, right? Like I twisted my ankle. Okay, well, that twisting action. Well, that may be something that is connective tissue related. It might be a sprain or a strain, right? Or it could have fractured your fibula or tibia or fibula. Like, it allows us to look at those things and go, okay, let's start from the part where we know is probably most injured, and we can work out from there and make sure that, is that going to lead to probably something that's like, oh, is it a shoulder injury? It might have if you fell from that ankle injury. So it helps you think through where else could they be injured from that initial presentation.
Hyper focused on just that thing.
Yeah. You look at how it could have influenced the whole body. So we've got, lots of things to consider when it comes to mechanism of injury. But, that leads us to, well, what are the things that could happen? You know, there's a bunch of different ones. Like, what are they? Like, what are we looking at here?
You have a fracture, which is the physical break in the bone.
Yeah, I mean, all of us have heard about broken bones before, right?
And you have your closed fracture where the skin's intact, so it's something that where they have the break.
Yep, the closed fracture. What types of fractures are we looking at here? What have you seen, Jonathan?
So I've definitely seen a lot of closed fractures where we don't necessarily have that bone poking out of the skin. But I have seen several open fractures where we do indeed have that protrusion through the skin. They're pretty gnarly looking. They can be, distracting injuries, and it's the issue with those are the potential for infection. Right, because we're exposing that bone to the, all the creepy crawlies out in the environment. We talk about crush injuries. You could have comminuted fractures where the bone is actually shattered by whatever that crushing force is. We were talking about pediatrics earlier, and the green stick fracture, right? It's an incomplete break that pediatrics typically have, right? Because their bones are still forming and growing. And then you can have impacted fractures. I've definitely personally dealt with those in my fingers and hands, where martial arts class. Where you're driving one end of a bone into another bone, and it's there's force being applied to those bones, so you may fracture the bones there.
I would imagine those exist a lot in maybe runners or people that are impacting their legs,
right,
or their limbs on stuff in a very repeated and violent fashion.
That's true.
Yeah, like when those bones are kind of hey, we're gonna take both these ends and kind of compress them together. That I think that leads to a lot of long-term injury too.
100%.
Right. Got some concerns though related to any sort of fracture, right? So we talked about the open fractures, and bleeding may be obvious with those, but even in closed fractures, we could have internal bleeding. Nerve damage with any sort of fracture, soft tissue damage, because as Max pointed out earlier, we could have jagged bone fragments, or the ends of the bones being jagged, moving and working their way around against the muscle tissue, and potentially even your vasculature, causing that internal bleeding. And I already mentioned infection with those open fractures. So those are some things that we need to be concerned about. Some of these things may not be the most obvious to us. So doing a good assessment is going to be hopefully a time for us to find those clues that indicate what sort of fracture this is.
Right.
You know what I forgot to tell you guys about? I actually saw probably my first deformity as well recently. So I went skiing last weekend, and I'm not on ski patrol yet, but of course I'm the guy. I'm I'm an EMT. I'm gonna help. So I saw some kid fall, and he was not getting up. So I went over. I took my skis off. I made a big X in the snow, because the first thing in my head is seeing safety. I'm I don't want anybody sliding into me and blowing past me or whatever. I want to make sure that we're safe, right? I don't know what I'm supposed to do yet on ski patrol. But I was hey, let me do the thing that an EMT would do. Go over, make sure the kid, hey, he's breathing. Okay, good. Did all this stuff. And then, so by the time I actually did that, somebody else, an actual ski patroller came up, and he started, right away doing a full on trauma assessment. And I'm okay, cool. I get to watch somebody who actually knows what they're doing do this. And I'm oh, it's kind of what we do. It's the same thing. And, he did a full body trauma assessment, and all of a sudden got to the knee, and the kid was oh, my knee hurts, and he goes there, and I see his hand stop, and I look at the knee, I'm oh, that's the painful swollen deformity right there, and his knee, on the side of his knee was a big old bump, and I'm that's not supposed to be there. I'm like, I don't know what that means. And he's got too many clothes on right now to know whether or not, like, what exactly is going on there. But I'm pretty sure that's the problem.
Yeah.
So they packaged him up and they slid him down the hill and took him and assessed him and did all the stuff in the medic room. But I was like, oh, I actually got to see my first kind of like, musculoskeletal trauma assessment in the field off duty, I'm just living EMT life all the time now.
It's just surrounding me no matter what I do.
Yep. I can't get away from it.
I think you also had them come to you for this
Oh, well, that wasn't bones or joints or anything. We'll get to that in a minute. Because like we're going to talk about sprains and strains.
Yep.
And although I don't know if what happened to me fits into either one of those categories.
Yeah, like a partial tear.
I had a partial tear,
right?
Which, so we could talk about it too, because like the breaks are like the big thing that we're always looking out for, right? Those cause like big bumps, and like a break is very definitive. I find that the things that are related to those, like the joint injuries, are much harder to know the severity, because every time I've ever had a bad like joint injury, it feels like it's the end of the world. Like, I'm dying. Like you just take me out to pasture, shoot me in the head, turn me into glue, right? Like the horse. Like I'll never walk again, Pa. And like those are really hard. So you have these like sprains and strains, right? So sprains are injuries to the ligaments,
right?
The connectors to the bones,
right?
And that's where you start seeing like some of those really bad sports injuries, right? Like you're talking ACL, anterior cruciate ligament, and the interior cruciate ligament, like those, the ones that hold the knee together. Yeah. Like everyone always talks like, if somebody has like a ligament injury, usually it's that.
Yeah.
Or like shoulder ligaments. But like that's the big one.
Yeah.
Like
the knees seem to be like there's, the reality is if you're moving with a lot of weight and a lot of force, like that joint there is going to take some direct abuse.
Right. And a full tear, break, or whatever you want to call it, of the ACL, the anterior cruciate ligament, is like, it basically makes your leg like swing inward.
Yep.
And you have no structure in your leg because you lose that ability. Those are really bad. Like we said before, like the bones are connected together through the ligaments. If those things break, the bones just fall apart with meat surrounding them. So those are bad, but they don't have to break completely or tear. They could just hurt a lot, or you can get partial tears and stuff. Same thing with muscles.
And the tendons.
So you have tendons.
Yes.
Attaching your muscles to your bones, right? And that's even trickier because you have the tendons themselves. So like your Achilles tendon, you'll hear stories of like these horror stories of somebody who like tears their Achilles tendon.
I've seen it happen, and it was like visually was disturbing because you saw this thing literally roll up the back of his leg. Yep. Like it was just this little ball that got bigger and stopped at like the middle of his thigh. It was just disturbing.
Yeah, a full tear or a full rupture, whatever they call it, of that tendon that's connecting the muscle to the bone, can completely make the ability of using that joint undoable, because it means that they have nothing pulling anymore for that direction. So you can have an injury in the tendon itself, or you could actually have tears in the muscle.
Yes.
Which I learned the hard way.
You did.
Also while skiing. It's this whole learning process for me this year, is learning to hurt myself and then, help other people.
There's no better instructor than pain.
Yeah. I certainly will not do
just no better
what
instructor.
I did. I did something stupid on skis. Nothing like crazy or dangerous. I just I was inexperienced in like doing something that was more advanced than I was comfortable with. And like I turned the wrong way and I caught my skis in the snow, and then my body went forward and the skis stopped, and I hyperextended my gastrocnemius muscle, which is your calf muscle. So hard that it went pop. And I instantly thought that I was, to be sent off on the ice floe, and that somebody should just put me out of my misery, because I'm like, I'll never walk again, and all the things that I'm working towards in life, like being an EMT, I'll never be able to. I horrible anxiety in that moment.
Well, I mean, I tore my bicep, and we were lifting a 700-pound range onto a pallet, and like there was no warning.
Yeah,
There was no warning whatsoever. It just felt like a rubber band popped in my arm, and I said, I just tore my bicep.
Yep.
And I was like, I'm screwed. Like, my job involves using my hands. Everything I do involves using my hands. I'm never going to work again. What is this going to do to me? All in a matter of 10 seconds.
Isn't that the worst? Like,
Yes.
as an adult, you have all of this anxiety and responsibility that falls on your shoulders. This is why kids are awesome at sports, by the way, because they don't have any of those. None of that weight falls on them.
Nope.
Yeah.
Right?
Yep.
Well, and fun story, at 25, I found my old skateboard from when I was a kid, and for about 2 seconds, I was like, oh man, I'm going to get on this thing. And I was like, you know what? I don't have health insurance, and it's a good idea to stay off of this thing. I eventually took it to the skate park and let some kid have it. So
Yeah.
I was like, better them than me.
So, long story short, I experienced a partial tear in my muscle. Not, I might have been in the tendon, but it was definitely the muscle itself. And that put me out of commission for it was way less serious than I in the moment thought it was, because I couldn't walk in the moment. I was down for the count.
And just so you know how fast he responded and recovered from this injury, 2 weeks after it happened, he was talking about how he was going skiing in a week. And both me and Jonathan were like, that's a horrible idea.
I did fine. I went skiing 3 weeks after, and it felt great. And I went skiing this weekend, and it felt great.
It was still a horrible idea. Just I'm gonna.
you gotta.
Sometimes
not a good
life's
idea.
short. Take chances, guys. Come on, you know.
take chances and then have that moment of my life is ruined.
Oh.
I can't ever do the things I wanted to do.
I worked an EMT shift 4 days after
Yes,
I
you
did
did.
it. I wrapped that thing up super tight and took some Tylenol. And I was like, I can make it 6 hours on a shift. I was fine. It was a little sore. It was, but
Well,
I was at that stage
yeah.
though where it was like walking around on it made it feel better. Like the longer I walked on it, it was better. But then the next morning it hurt a lot. You know what I mean? Like, muscles are weird. I think they're different than, like, or at least responding to the pain from them. Because if you work them enough, they get,
well, you get blood flow.
Yeah,
the blood flow and
I don't know what the
healing
actual,
and yeah. I mean, no different than me with my damn arm and moving a refrigerator by myself.
Yeah.
And like 3 days after. Anyway,
So you got all these things, right?
Yeah.
We have breaks, we have joint injuries,
Yes.
we have the strains, the sprains,
dislocations.
dislocations. We didn't really talk about those, but like, I've seen somebody dislocate a shoulder. Oh, Max has dislocated a shoulder. That's pretty gnarly.
It was incredibly painful. And
Right.
then I'd seen Lethal Weapon, and I was like 18.
What did you do? Just jam your shoulder
There
into
was
a wall?
there was a concrete wall, and I'm like, it's like 9:00 in the morning. I have a full day yet to do. I can't miss a day of work, and I slammed my shoulder into the wall, and it hurt just as bad as a dislocation. But other than being sore and swollen, it worked.
Well, that is not in the scope
Yeah,
of
don't
the
do,
EMT
I'm saying,
practice.
Don't do that.
So,
I was
just
dumb.
disclaimer.
I was dumb. 18. Yeah.
There are proper ways to
Yes.
put a
Reduce.
reduce. Right, that's the term. Thank
Yeah.
you. To reduce a dislocated joint. It is not part of the EMT
No.
scope. You should not do it without knowing how to do it. But again, another shout out to like the Pit. They've shown that on
Yes.
there a few times, and other like popular media. It's a relatively quote unquote simple procedure in terms of like, essentially you have to apply traction. We'll talk about traction in a bit in terms of like pulling something away, because you have to alleviate the tension that's happening from that thing being in the wrong spot, and then usually that'll get it aligned and then back into the thing. But if you don't know the right anatomy and how that thing should be aligned and the right place to pull and tuck and do all the things, you shouldn't do it.
No, you shouldn't.
But dislocations are big. Shoulders happens to fingers, hips. We'll talk like, that's one of the big ones that we've learned about too, or especially hips, hip dislocations versus hip fractures. That's a big one to be aware of. Even knees can be dislocated.
Sure.
Even though that's more of a simple joint, it could still get dislocated. But like usually you'll know because they'll be deformed. There'll be a lot of pain.
An incredible amount.
Because usually it's pinching a nerve, I believe.
And honestly, the weirdest thing about it was like the burning sensation that came with it.
Yeah.
Like,
And
I haven't had too many things that had that burning sensation with it, but that was very, 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 very odd.
It's probably because nerve pain can be like your brain interprets it in many different ways. So yeah, a lot of different things to that you can get injuries in. All of which I think the common one between all of them is pain.
Yes.
They're all painful.
They're guaranteed to be painful.
Yeah. Well, not guaranteed, I guess, but it's sure likely they're gonna hurt.
Well, here's the thing: if there's no pain, then that could be a very serious sign, as we said before.
Yeah. But okay, so we've talked about the things that can happen. What do we do? Like that's really where we need to start working this conversation is like, how do we assess like how bad they are, what we need to do next. This really ties into the medical term of the week in terms of like, all right, so that you have this injury and we go into the 6 Ps, we make sure that there's CMS, we're assessing, making sure that, hey, how bad is this injury, right? But there's other things we need to keep an eye out for too. And this is where we get into some of those big warning signs. So, the compartment syndrome is the big thing that we're looking out for. And we talked about that. We're using the 6 Ps, making sure that doesn't happen. But in terms of assessment of the injury itself, the first thing that we're doing,
you got to touch it, palpate it, see where their pain is at, see if they have that swelling.
Right.
Is there some kind of a deformity in the joint or in the arm? In other words, does it look like it shouldn't do that?
Exactly. And like there are things that we're doing for the injury itself. However, what I will say, or what I will question you guys in, if you arrive on scene, you see somebody with terrible, catastrophic musculoskeletal injury on their knee, or both, they have bilateral fractures on their legs, their knees are dislocated, all the things we just talked about. They got all of them going on. Is that the most important thing that we should be looking at?
No.
What is?
Life threats.
Life threats.
Our ABCs.
Yep. And that to me, all of this story, like, yes, there's a lot of things that we need to keep an eye out for the musculoskeletal stuff. However, it's the thing we always talk about. We have to come back to the life threats first, because if they can't breathe or if they're bleeding out,
it doesn't matter.
What their legs doing if it's pointed in the wrong direction. And this is kind of one of those things that we that they really hammered home for us in terms of, don't splint somebody to death, right? Like if you come up on scene, like you could start splinting all of the limbs, but if they're bleeding out from an arterial bleed in their arm or whatever, that can kill them a lot quicker. Their musculoskeletal injuries won't kill them. They'll just really hurt. They'll be really distracted.
What's going to kill them first? Now, if you have an open fracture and there is examination going on, they do have a hemorrhage or bleed, yes, you have to treat that. But you're then rolling right back into your assessment and into their vitals. Like, you've got to make sure that you cover the things that are going to kill them and then move on to the things that are going to make them more comfortable, that are going to give them a better result after care.
So really it comes down to this. Like, this is the procedure that they taught us. Number one, primary assessment, treat for life threats, right? Like that's ingrained to us. Everything we do, we're always treating for life threats first. Controlling bleeding, usually, because bleeding can eventually get worse. We want to make sure that we're handling that before we start getting into musculoskeletal injuries.
Yes.
Right. That kind of soft tissue trauma. If there's bleeding, then we want to start getting into immobilizing.
Yes.
Like that's the primary thing. is making sure that things don't get worse.
Yes.
And in that process, we're doing a full assessment.
Mm-hmm.
We're doing a trauma assessment. We're going head to toe. We're looking for all the things that we were looking for earlier in the 6 Ps, maybe even some other things too. One of the words that we learned about, one of the things that's a huge sign of possibly some trauma is crepitus, which is
just the description of that just gives me the willies.
Yeah, like the sound of like Rice Krispie treat or Rice Krispies and milk, like that, or like, you know, as you're palpating, it gets you feel crunchiness.
Mm-hmm.
That's a sign that things have broken on the inside.
This is a bad sign.
Yeah,
limbs and such are not supposed to feel like that when you touch them.
Or a reduced or extended range of motion.
Yeah.
Like if a joint turns more than it's supposed to turn or less than it's supposed to turn, that's bad.
It's
like,
not a good thing.
Yeah. So we're looking at that stuff. We're doing a full assessment.
Mm-hmm.
And if we're finding something that should move and shouldn't, or, you know, something along those lines, we're making sure that it's no longer, or if it's moving and it shouldn't move, we're making sure it doesn't move anymore.
Yeah, we're
right?
applying whatever the appropriate splinting is.
Right. While
or actually just the appropriate immobilization.
Yeah, we're immobilizing.
Yeah.
Because we may not be splinting right away,
Right.
but we're making sure that somebody's not flailing about or they're not moving. We're making sure that we immobilize first, and then, you know, we check pulses, make sure that things, you know, if somebody's distal pulse is there, if it's not, aligning that to a natural position to see if that blood flow will return, that hopefully that pulse will return, and then, you know, we assess and go, okay, what needs to be splinted? What do we need to do for transport to get this patient to care, right? And then transporting them. So, like, that is the kind of process that we're going through in the assessment. And really the thing that we're looking for the most is those life threats. We're making sure that we're stabilizing them, not making anything worse. But, and this can't be understated, because obviously the common theme to all trauma, the one that we've talked about in pretty much every episode so far, and we will in all the episodes moving forward in the trauma block, is what's the thing that we treat for in every trauma situation?
Hypovolemic shock.
Just shock.
Shock.
We always treat for shock
in general.
Yep.
Yeah.
Yep.
We have to do it because those injuries may cause
Lack of perfusion.
And that is what we need to make sure doesn't happen. And the easiest way we can do that is keeping them warm, making sure they're not hypothermic, laying them down so that they get better blood flow.
Yep.
Giving them oxygen so that they have better perfusion. So those are the things that we can do as EMTs to make sure that they're
if you're covering your
not getting shot.
Yeah, if you're covering your basics, you're covering your life threats. You're making sure whatever the injury is isn't getting worse, and then you're treating for shock during transport. That's pretty much the story of what we do. It's just with different interventions along the way.
Yeah. All right. So let's bring this thing home to some splinting, because we've talked about the process, right? We talked about the body, what the parts are, what injuries can happen. We've talked about the assessment.
Yes.
We've gone through that portion. We've seen there is something that needs to be splinted.
Right.
What are we doing? Like, what are the goals here?
So we've got to be able to visualize the injury. So we may have to expose the injured area. That could include cutting somebody's pants off. That could include getting their shoes off. Maybe even cutting them off if need be. But we've got to expose that area first so we can visualize what exactly we have going on. Again, the other thing is controlling life-threatening bleeding, right? So we have to take that into account as well. So if in that process of exposing that injured area, we see some life-threatening bleeding, we got to deal with that first.
Yeah, we back up on the importance scale, right? Like, oh, we found something new. Let's take care of that. Then we come back.
Right. And then we want to immobilize the joint or the injured area to the joints above and below the area, and then hopefully we've got padded splints we could utilize. But before we even get into that, we want to assess for that CMS, right, of that leg. So we're doing that, assessing first before we do any splinting interventions, and then afterwards we're checking our CMS again, because we may have put them in a position where we have caused some sort of occlusion or thing like that. We may have induced, right, some sort of stop of the blood flow. So we want to continue to assess that. And the big things is we have to think about, well, why are we splinting in the first place? And in part, it's to reduce pain and to prevent further injury. We're going to have to move these people, and we've kind of talked about it a little bit, but moving them from the point of injury to definitive care, there's a whole lot of movement involved, and that's, we're going to have to stabilize and splint those injuries before we can move these folks.
Right.
The other aspects, we may come back and deal with any sort of secondary bleeding that's going on, and with our CMS assessment, PMS assessment, right, protecting nerves and the vasculature.
Yeah.
So
I mean,
those are some things that we. Yeah, those are some things we want to consider.
So, it just dawned on me too that while we're chatting about all this stuff, we haven't really described what a splint is.
True.
Because to us it's second nature. There's a bunch of different types of splints. We're going to be talking about some tonight. But just to kind of throw this out there for anybody who might be listening this deep into the episode, doesn't know what a splint is. It's essentially taking some sort of rigid, or maybe not rigid, but a stabilizing material.
Yes.
Yeah.
And aligning it to the body, and then basically bandaging that item to the body so that it's giving support, so that say you have a broken leg, you can take something as simple as a walking stick. I learned this one in the Scouts when I was a kid.
Yep.
That can be a simple form of a splint.
A branch.
A pillow can be a splint. So like if you hurt your ankle, well, if you want your ankle no longer to move, and somebody can help wheel you around, and you want some support to make sure your ankle isn't wiggling all around as you're moving, well, you can put a pillow, wrap it around your ankle, and then wrap that around your foot. That helps keep it from moving. It's not a rigid item, but it's something that will keep it'll help stabilize.
Yeah, all you're trying to do is just hold that form.
Yeah, it's like a gentle set of hands, just holding holding that thing still. That it can be as simple as that as a splint.
Agreed.
It could be a popsicle stick on your finger.
Yeah,
like wrapped with some tape.
Yep.
Like that is probably the simplest form of a splint. Actually, I will say the simplest form of a splint is probably taping a broken finger to a non-broken finger.
Done that. Or toe.
Yeah, or a toe. I learned that one as a kid.
Sure.
Like, if you have a broken finger, you could tape it to the finger next to it, and then all of a sudden you keep your finger straight.
Yep.
And then hopefully it heals itself, or you go to the doctor. We didn't go to the doctor for broken fingers as a kid, but
no,
it probably should have.
Yes.
But like that's. Sorry, go ahead.
Yeah, Mike. They've fallen out of favor for spinal injuries, but even if we've got multi-system trauma or a multiple musculoskeletal trauma, we could even potentially use a backboard to splint the whole body. There's a couple times we want to avoid that, but yeah, even in it's one of the few instances now where a backboard still may have some limited use.
Yeah, I mean that's its most extreme, right? Like if the simple thing is a popsicle stick on a finger, well, what if you need to immobilize the whole body? If you're just like, hey, we need to splint so much stuff.
Don't you just get all the popsicles, just glue them together, lay out, wait for them to dry?
That'd be a lot of popsicles.
And then roll them on. I mean, it would take a few days to get them all. You have to eat them first.
We got to eat them first, right?
And watch for brain freeze.
And maybe they might appreciate a little bit of a sweet treat.
Well, no, we're giving.
Oh, we have to eat all of them?
Yeah.
No, that's
a lot
of sugar.
That's why you have all the firefighters come over so they can eat, see more.
Firefighters are good for something.
And I mean, a day later, we'll have a proper backboard made of popsicle sticks, and then we can move the patient.
No. But the backboard is obviously the large extreme of
Sure.
you know, it's the supersized popsicle stick, right? You're putting a whole body on the popsicle stick, and there's so many other forms of splints too, and like really cool things nowadays in terms of like air splints and whole body vacuum mattresses.
Yes.
So you can get really complicated with splints, but I just wanted to kind of throw this out there that like the process of splinting is not necessarily a specific tool.
Nope.
It's not a specific practice. It's the principle of, hey, let's immobilize this thing with the aid of something that'll help support it. Right.
Like it's a basic thing that anyone can do.
Right.
With almost anything. I mean, there's some things that are going to do a better job of it, and there's specific tools that we have that are very specific for that thing. But just the idea of something, it doesn't have to be complicated. It can be very, very simple.
But to what Jonathan was talking about before, like the goals are simple.
Yep.
Right. We're trying to reduce the pain.
Mm-hmm.
We're trying to prevent further injury.
Yep.
Reduce bleeding if that is a concern internally, like from a bone fracture or pelvic fracture, because you know those are all things that can cause some serious bleeding internally.
Yep.
And we want to protect those things from getting injured more, like the nerves and the vessels. So that's the goal of splinting, and you could do it in a bunch of different ways. And we'll talk through a few of them really quick, because there's like if you look at it as a principle, as something that can be used in different ways, it becomes a lot easier to understand.
Sure.
And you know that you have all these tools at your disposal to go, okay, well, how can I be creative and use this thing to help splint this? Now, luckily in EMS, we have a bunch of tools that they give us to be able to do that. We have traction splints, and we have malleable splints, and we have longboard splints, and we have pelvic binders. Usually we have soft splints, air splints sometimes.
I mean,
the list goes on of things that you can probably find on an ambulance to help splint things that are meant to splint things. And then there's probably other things that you could use, like pillows that aren't meant for splinting but can be used for splinting.
Right.
Yeah.
So lots of things out there, but we have a few kind of specific injuries that can probably be talked about that may need some specific concerns.
Yeah.
Right.
Sure.
The number one that comes to my mind is like shoulders. Because that's not like when you think of a splint, you think of something that aligns a bone together. But like when you have a shoulder injury, it's not really a splint per se. You're kind of splinting it because you're using the body as stabilization for the joint. We're using something different there.
Yeah.
We're using a specific type of splint, which isn't necessarily taking that shoulder and rigidly holding it there. You're using a sling.
Right. You're just trying to hold position.
Right. A sling being like, okay, I'm going to take my arm and rest it in a cradle in front of my body. And all of a sudden that helps immobilize my shoulder because I'm not moving my arm.
Yep.
Like the injury isn't necessarily in the arm. It can be. If you have a bunch of injuries on a whole arm, you could have an injury to the shoulder. You can have an injury to the humerus. You can have an injury to the radius and ulna. Like if all of those things are hurt, this same method works for all of it.
Exactly.
You're going to splint those things that need the splinting, and then you're going to put the whole arm in a sling so that nothing moves and it's supported. And with the shoulder involved, like especially, but for both of them, you also want to consider using a swath, which essentially is just a piece of cloth that helps wrap around the body that holds your arm into your body so that it's not swinging. Yeah. So all you're doing, nothing is super tight.
Nope.
It's not constricting, but it's just trying to put that arm in a spot that's in a natural position that isn't moving.
You're allowing the sling to take the weight of the arm off of the joint, and then when you're having to move somebody, I mean, if you've never had to move somebody, it can be awkward. It can be in tight quarters. So that swath allows it to stay tight to the body, so you're not doing more injury to that arm as you're moving them in and out.
Yeah. And for that, we're using something like as simple as, actually, it's one of my favorite things that they give us in EMS, triangular bandages.
They're awesome.
The cravat.
The cravat.
They're infinitely useful.
I like to refer to them as neckerchiefs.
Because he was in Scouts.
Yeah, because it's a triangular piece of cloth that you could wear around your neck, like a cowboy or a scout. Yep. And that's for anybody out there, that's why they wear that's why they wear neckerchiefs in the Scouts. It's it was a multi-use tool back in the day. Now it's just an ornamental item, but you could take that thing and turn it into a sling.
The contents in the Scout book of what you can do with your neckerchief is extensive.
In my original Scout book, they showed you how to turn it into a tourniquet.
Yes, they do.
And then promptly told you never to use it that way.
They still do. To this day, they still do.
With a windlass
Yes.
and a neckerchief, you can make a tourniquet. I'm sure it makes a terrible tourniquet. But anyway, so like the triangular bandage is one of those things that's very well suited for this role.
Sure.
Hey, it's the right shape. You could put it in a way it makes a sling. Is it a little bit more work than, say, something that's specifically made for a sling? Maybe.
It is.
Yeah.
It is.
But it's a multi-use tool because you can then use that triangular bandage for securing splints to other things. So, sometimes it's nice to have something that works in multiple different ways.
You mean something as simple as a piece of fabric?
Yeah, cut into a triangle.
In a multi-million-dollar piece of hardware carrying.
No, it doesn't count unless it costs like 3 figures.
Exactly. It's not even EMS ready unless it costs 5 or 6 fingers, right?
Yeah, but there's a bunch of different those upper arm injuries, things that involve the shoulder, or even the clavicle is a big one, like that the collarbone.
Yep.
That can be something where you really want to help immobilize the shoulder, like that whole arm, to make sure that it's not aggravating the injury and it's keeping things stable, not causing further injury. But yeah, so those all fall all into that category. What about the lower body?
Then you get into pelvic injuries.
Ooh, pelvic.
Yep.
This is the dangerous one because I will say, there's 2 in lower body injuries that are to me the biggest. That's crazy.
If you have that, you need this.
Yeah, there's 2 musculoskeletal injuries in the lower body that can lead to immediate life threats.
Yes.
Right. Pelvic is one of them.
It's huge because you have major blood vessels running through a tight area.
Mm-hmm. With a lot of bone surrounding it.
With a lot of bone around it. So if the bone breaks, it could sever an artery. So using a pelvic wrap or binder like the one Sam makes allows you to.
An example here is the Sam Pelvic Sling 2, which is a really great example of a pelvic binder, by the way.
So you're basically looking at a wide piece of fabric, reinforced fabric, with a strap to tighten it. I mean, it's simple, but what it's going to do is hold that structure in place so it can't cause any more damage than it already has.
Right, because the pelvis is like a bowl, right? And if that thing breaks, it is super unstable and can open up further. And if it opens up further, it can cause further damage. It can open up blood vessels, and it is generally a bad thing. So we'd like that to be brought back together.
Yes.
Right. And stabilized, but not so much that it compresses it too much and causes further injury. So that's the tricky part about pelvic binding is it can't be super compressed.
Yeah, and it's not like you can see in there.
Right.
So and again with these some of these have the ability to cut off blood flow to the lower extremities, depending on what type you're using. But for this discussion, idea is you're just trying to keep that structure stable. So again, you can transport them to further care.
Yeah. So a pelvic binder is important.
Yep.
Important to know. And for those open book or those pelvic fractures, open book fractures, can really help stabilize that whole area to prevent what could be a life-threatening injury, because you can bleed so much from your pelvis
because it can hold so much fluid.
Because it can hold a lot of fluid.
Yep.
There's a lot your bladder's in there. There's a lot of stuff that can compress to make room for blood.
Yeah.
And those are things that can cause hypovolemic shock.
Sure
It could kill somebody. Is there an alternative to a pelvic sling?
Well, there is. You could always just use a sheet.
They told us that.
They told us that.
I'm sure it's good it works in a pinch, but
Yeah,
commercial devices are generally going to be better.
Yes.
I've seen a lot of improvised pelvic slings being used in the field over the years, but positioning is always an issue with them, and getting them wide enough to where you're applying the compression in the right spot is always an issue with them. It will do in a pinch if you don't have anything else, but my preference is a commercial device like the SAM.
Or a pelvic bind. Like they make some that look like intricate, like Victorian corsets.
They do indeed.
Yep.
It's so weird, but like, hey, if it works, it works, right? Like,
right.
I just think that those things that are purposely made for that particular purpose, I think are going to be more effective because they conform to the hip instead of it trying to figure out how to make it work with a sheet. But,
I mean, if nothing else, it's going to be more efficient, and you need efficiency so you can get moving and cut down on the time spent.
Yeah.
Well, it's a comfort thing as well, as far as, we're talking about reducing pain, hopefully. And, what are the chances you get it exactly right every time with an improvised pelvic sling?
Right.
And it's just,
So I've actually heard some stories about how pelvic slings can help with pain beyond the emergent space, because sometimes people need a bit more support, like, for like knee braces or joint braces, where devices like that can even provide some relief of pain. But that's not necessarily in this space, but it's just like, there are things out there to help kind of, patients in different categories. So we talked about like the pelvis, right? That's a big one. While we're in that space, actually, before we go into anything else, what's the other lower body like a lower body injury that is probably the biggest red flag?
Broken femur.
Broken femur?
Yeah, and you need a traction splint.
Why is that?
So, with a broken femur, you've got, and we're talking about a mid-shaft femur fracture. You've got the femoral artery running along there. And again, we talked a little bit about, major one, right? When we talk about like traumatic injuries and bleeding to death, that's usually the one that we talk about the most when it comes to limb injuries, because of how quickly you can bleed to death from it. So with a closed femur fracture, we have a couple different interventions, but the big thing is that you've got sharp bones, and they're pointing into vascular potentially, and it's the other aspect of that is even if they're not into the vasculature yet, they could work themselves into there, and it's also extremely painful, because all of those bone fragments are pointing into muscle tissue as well. It can truly be a life-threatening injury. So the big thing that we use to intervene in that closed mid-shaft femur fracture is going to be a traction splint. So we talked a little bit about traction. So we're basically going to pull and apply pressure, pulling away from the injured area. But the issue with pulling traction, once you pull traction, you've got to maintain control of that. So if you're not ready to do that, you don't want to pull traction yet. You need to make sure you're ready to do that, and hopefully you have a traction splint available to start that process, and go ahead and get that situated.
Yeah, because like the muscles, if you think about it, muscles, their job is to pull things all the time. That's their job, right? They don't work in any other way. They just pull. So if all of a sudden you have this big, long bone that's always in the middle of this giant, powerful muscle that you work every moment of every day when you're walking. If that thing breaks and all of a sudden starts pushing against each other, you have this muscle that's constantly trying to like pull it together, compress that thing together. Like it's meant to do that. So you have to like to open that up is relieve some of that pressure in between the bones, and the only way to do it is pull it apart, like to work against that muscle.
And it is one of those things that it's so specific. Like there's a lot of things that all the different gear that we have and all the different tools that we use. But that is one of those things that is very, very specific, meant for one thing. So, and I think that kind of highlights it as a very interesting item because of that.
I will say, seeing the traditional form of a traction splint in use is what we used in EMT school.
Mm-hmm.
It seems like the most archaic, dungeon-worthy device you can ever imagine.
It looks like a medieval torture device.
Harris, the Harris traction splint.
Yep.
That thing, it looks like a crane gantry, and it's so gigantic that it sometimes requires you to have to put the patient backwards on a gurney so that they can actually fit inside the ambulance, because it sticks out past their foot so far that there may not be the clearance for them to fit in the ambulance with that thing and the doors closed. So know which one your service uses. Another quick shout out to the Schlissman traction splint. This thing,
tiny.
We're going to talk about this for sure in a future episode. That it expands out. It does the same job. It's way more elegant and it's awesome. That one is also from Sam too. They make, for some reason, they've really kind of nailed it in this the trauma space, and like that one, the Schlissman traction splint is a way better solution than that gigantic.
The form factor of this is a fifth the size of the Harris.
Yeah.
And when you have an ambulance,
it's not even a fifth. It's
even less than that.
Less.
Like you have,
especially folded.
You have such tight spaces for everything you have to carry. So the idea that you can put something that is this small and do the same thing is pretty amazing.
Yeah, so there's different tools available. We have we've been very fortunate to kind of experience a few of the things through our sponsor, and I'm sorry if this sounds like a constant plug for them, but they're really smart products.
Yeah.
And it's a tool that exists that is better than other tools. We're always looking for the thing that we can learn from the best and kind of, use. And that seems to be a really good option for it.
Mike, is that the version? Is that the compact version that they sent us?
It is the compact version. Yeah.
And I remember in doing some training with that with appropriately sized folks, we could even maybe use that on pediatrics, because it is able to kind of fit their anatomy a little better at certain ages. So
it's just more versatile, and it certainly seems a lot easier to apply than that torture device that.
I think this is one of these items that you really have to make sure you get training or whatever. Because there's so many components to some of them that if you don't get training on use of them, you're going to be lost quickly.
Yeah. But before we get off the subject of a femur fracture, the one thing, and I know this is a key takeaway for me when we learned about this stuff. We're always concerned about the possibility of internal bleeding. Now, there's only so much space that blood can go to. Now, they say that a femur fracture can cause like 1 liter to 2 liters of bleeding in the thigh itself, which is a lot. Yes. I mean, you can only lose so much, right? Now, is 1 to 2 liters lethal on its own? Probably, maybe not, depending on how much you're losing internally. But the stacking tolerance of that versus the chances of other injuries at the same time, like who's to say that somebody hasn't lost 1 liter from some other injury?
Right.
And all of a sudden that internal bleeding in the thigh is putting them over the top or dropping them below a sustainable amount of blood in their system. So while it may not always seem like, oh, well, that's not enough to really harm somebody, you have to think about they may not be fully healthy in the first place. Losing those 2 liters could be 100%. The thing that puts them over the edge.
And if a trauma that is forceful enough to break that bone, like you said, the odds are they have other injuries.
Yeah, some sort of other injury.
I mean, it's not going to snap easily. So you really, if you see that fracture, you should be looking them up and down, because there's almost a guarantee there's other trauma going on.
Yeah. So lower body.
Yep.
Some of the other ones, the big one that we kind of touched on very quickly before, hip dislocation versus hip fracture. Couple of key differences between them that they taught us that I thought was really interesting. Obviously, they're different injuries. A dislocation is going to feel and probably present differently than a hip fracture.
Right.
However, the end result is they can't walk or they can't self-ambulate because it's just so painful or not able. Actually, I saw a hip fracture once that wasn't painful at all to the patient. She was like 80 years old and walking around with a walker and a legit hip fracture. And I was like, geez, that's crazy. It's because she wasn't putting a lot of weight on it.
Right.
So there's a key the big difference being what's happening. One's out of the socket, you know, and it's possibly pushing that anatomy in a certain direction. So with a hip dislocation, you might see the foot point inwards.
Right.
And obviously a dislocation is going to be very painful. But it can happen from trauma, from high energy type things that leg can become dislocated. So you might see that kind of point in one way, or you might see a shortened limb, which is present in both that and a hip fracture, actually. So if it's out of the socket, those muscles may pull it up and shorten the leg. So if you're looking at it versus the other leg, one may be shorter. The hip fracture, the big difference being you might see that thing pointed outward, because and it's really not a hip fracture. No, it's actually a femur fracture, but it's a
fracture at the top of the femur.
It's a fracture, like the head of the femur.
Yep.
So in that instance, the muscles in the anatomy might be pulling it outwards.
Right.
So you might see an outward facing leg. And they might have pain in a different spot, but you know, really it's the same treatment. Like we're immobilizing, we're putting them in a position of comfort, and we're getting to the hospital because we can't really do anything for those two things in the field. So, but those, you know, you may get other injuries to the hip area that aren't necessarily like a pelvic fracture.
Exactly.
So you want to make sure you're mobilizing and getting them to care.
Yep.
And the last one, like the leg injuries, like I kind of put these all into the same category. You guys let me know if you think there's a big difference here. So if we're talking about splinting, we're talking about injuries to the knee, injuries to the tibia and fibula, like the bottom, you know, the lower leg, injuries to the ankle. Essentially, we're doing everything we've talked about before.
Absolutely.
We're immobilizing whatever that thing is. If it's a joint injury, we immobilize above and below, and we make sure that joint doesn't move.
Right.
If it's the bone, we immobilize the bone, make sure the bone doesn't move. You know, it's the same thing.
It's almost the same application across the board.
Yeah, splinting becomes a lot simpler when you realize, hey, I'm stabilizing, I'm checking for PMS, I'm positioning for comfort and for pulse, you know, making sure that they have good circulation, and I'm, making sure that I'm trying to alleviate some of that pain, like it's the same thing.
Yeah.
So that's really the kind of, I mean, I know there's a lot, there's so many, and I'm sure we could probably talk another hour on the specific injuries and exactly what you do in those situations. But I would for me, it was learning the principles.
Yes.
And understanding to apply those into different situations. And I'm quoting Bob Waddell from SAM on this, like splinting is about creativity. It's about understanding what you can do and then what tools you have at your disposal and how flexible those tools are to then use for what you need them to do. And if you can grasp that, I think you're going to be in a pretty good spot.
I think it's no different than ABCs. Like these are your basics. This is what you have to work with. This is what you have to do and apply it across the board.
Yeah. Anything other on musculoskeletal injuries, guys, that you could think of?
Oh, we when we were talking about some of the actual procedures in relation to that, if we have injuries to to the arms, we want to place something in the hand that like a rolled up ball of Curlex, or maybe a towel that's rolled up, place that in the hand. So when you have those injuries, a lot of times the hand will draw up, and we want to put that hand in a position of function, right? So if it draws up, right, we've got all that swelling, all that different stuff going on. We may have some sort of issue with the hand being able to release when they're finally at definitive care. So anytime we're splinting, an arm injury, we want to place something in somebody's hand so they can maintain position of function of that hand when it all is said and done.
Yeah.
So that's just kind of a helpful thing as a reminder, if you're splinting something.
Yeah.
So position of function.
Yep. Yeah. Making sure that, and I'm sure that adds to comfort level as well.
Sure.
In terms of
just
somebody having something to squeeze, and they're just not like cramping their fist, and straining. Right. But yeah, that's a good one. Anything else on your side, Max?
No, I think we covered everything I can think of.
Cool. All right. So that brings us through musculoskeletal trauma. There's a lot. There's a lot to learn there and practice.
Yes. And again, like you said, you could go down the rabbit hole of the various bones of the structure and the anatomy and all that stuff. But as an EMT, the main thing you need to know is like, this is what you have to do. This is the process.
Yeah. Make sure you're assessing, you're doing your primary assessment, you're doing a good trauma assessment, you're finding those decap BTLS things, addressing them, taking care of what needs to be taken care of.
Yep.
And number one thing, like this, to me, this is what it all comes around to. Don't make anything worse.
Yeah, it's kind of like that's the goal of
try not to make
EMS
anything worse.
In general is don't do harm. Don't make it worse.
Yeah. Okay, so that brings us through and, allows us to continue into our tools of the trade segment.
Yeah, which this time is sponsored.
Yes.
By.
Can you guess who?
I think it's sponsored by Sam.
We have a tools of the trade sponsored by Sam Medical, makers of the Sam Splint.
Exactly.
We wanted to. Okay, here's a caveat though. So our tool of the trade this week is the Sam Splint. However, I will say it's not really a Sam Splint. I'm using it in the way that everyone talks about splints. Technically, this is a moldable splint.
Exactly. Malleable.
Moldable, malleable, whatever you want to call it. I believe there is a technical term for it in terms of the category of tool, the moldable splint. However, that's like saying there's facial tissues, but really everyone calls them a Kleenex.
Yeah.
Like everyone calls this a Sam Splint. That is the tool for tonight. Yeah. It just so happens to be sponsored by Sam Medical. And there's a bunch of different ones.
Yeah.
There's the legit ones made by Sam. There's knockoffs.
And the great thing about the Sam Splint is one, that bright orange color that if you're just listening to us, you're not watching the podcast, it's bright orange. It's either going to come folded flat. Sometimes you see it rolled in a ball, depending on which application, which form it is. You have different sizes. You have an 18-inch, a 36-inch. You even have ones small meant for finger splinting. So you have some basic forms of it, but when you go to pull this out of the bag, the fact that it is an orange color, it catches your eye, you see it, which is hugely important in my mind. And also, like, this is kind of, this is their form factor.
Well, another thing about the orange color is it's copyrighted. So you may find orange ones, but the orange and blue means that it's a legit Sam Splint. It's that's how you can know that it's theirs. But it also the Sam Splint itself stands for something, which is really the definition of the category.
Right.
So they say that the name actually means the structural aluminum malleable. That's what SAM stands for. However, it was invented by a guy named Sam. So come on, like I feel like that's a little bit of reverse engineering there. I'm betting, but either way, they made a cool thing here. So the guy's name is Sam Scheinberg, and he's a trauma surgeon from Vietnam. And a fun little tidbit about this thing. So the way it moves, the way it folds and stays in that kind of position, it's because there's like an aluminum aluminum structure on the inside, aluminum, like, thin aluminum plate, I guess you would call it, or sheet. And they got the inspiration for that from juicy fruit gum. So they were playing with the foil wrapper of a piece of gum. They were looking at that, and it held its shape. They're like, oh, I wonder if we can do something with that and keep it, do a splint with it. And they covered it with foam. They did that in the 1980s. That's where these things kind of came about.
Right.
And you know how much has changed since the 1980s?
Probably nothing.
Not at all. This is literally version 1.
If it ain't broke, don't fix it.
And the only thing that they've probably done different since then is they've printed instructions on the outside
That's
of them,
the other
which
thing
is
too.
super cool about them.
It literally shows you all the different forms that this is made for, and it shows you specific to the size you have. So having the 36 inch is actually showing you how to splint a lower extremity, how to splint an entire arm going around the arm completely. So anyway, the main thing is you can fold it and bend it and use it to what you need it to be done. And it's also lightweight. It's easy to apply. It's fast to apply.
Yeah. So like this is, and we're talking about SAM splints, but this is the category, the moldable splint, right? But what do we need to do for these, like, to use them? Because while they can be used in different places, they're different sizes, different applications. What's to me, there's one very important thing about them. And Jonathan and I got to experience the training from Sam directly on this. And it's probably the most misunderstood or underutilized thing for moldable splints. And I was surprised that this is the thing. Do you know what it is?
I do not.
So a lot of people take these flat, like, moldable splints, and they'll keep it flat, and they'll wrap it around a part of the body, and they'll keep it flat,
which really isn't,
which doesn't do anything, because you can still mold this thing and turn it in every which direction. So there's a malleable piece of aluminum on the inside. The most important thing with these moldable splints is to use the structure, or to turn it into a structural item. So you have to do what's called you make it some people call it the taco, the C channel. That is the most important thing, because if all of a sudden you take this thing and you bend it so that it's in a C shape throughout the whole thing,
now you have a rigid structure.
Then you can actually put pressure on this thing and it won't bend.
Right.
Like it is now rigid.
Right.
So you've taken this thing, which is malleable, foldable, in a bag. You've taken it out. It's now long enough to fit, like, my adult arm, and it's rigid.
Right.
And you don't have to go find a stick, which would not be comfortable, not covered in foam. So, like, these things are very useful for that instance, but you have to make sure it gets folded.
And one neat thing that I saw in the that I didn't know before is the fact that if you have to go for X-rays, they're able to see through it.
Yeah.
Which I that is something I was completely unaware of. So the idea that you have this thing that can hold traction, can hold form for the brake, and then they don't have to undo everything to be able to see what's going on in the arm is awesome.
Yeah, I don't think it holds traction.
Not traction, but form.
It adds stability.
Yeah.
Right?
Yeah.
Keeps it immobilized, keeps it from moving about. And it's just a tool that is easy to kind of carry with you. Now, to kind of, just to finish off on how to use these splints in general, obviously you make the C channel, you put it on whatever the thing is that you need to keep stable, and then you'd probably wind up just wrapping it and securing it with some other form of bandage.
Yeah, Curlex is nice.
Curlex works.
The fact that it adheses to itself makes it really, really, really handy.
Well, this is Coban.
Coban, sorry.
Yeah, so Curlex can work, like just regular gauze.
Yep.
But Coban, I think, is probably one of the better ones for this. Like, it's what we used in class, and I thought it worked really well for splinting. You can use triangular bandages.
Yeah,
they work, but that's a lot of tying knots. And
you have ace bandages, but I think I've seen the Coban kind of take the place of the ace bandage.
Yeah, also known as vet wrap, by the way. If anybody's ever wants to buy some of this yourself, it's literally the same thing
and much cheaper.
Yeah. Okay. I don't know if that's official, but hey, a little help here. Save on the wallet. It's the same stuff. But yeah, so those are the big things to keep in mind. You have to make sure that it's rigid. You have to make sure that you're doing all the things we talked about in splinting before, assessing CMS, making sure that you're not making anything any worse. that you have a pulse before you splint, and then you check the pulse after, right?
And then a little bit of history on the SAM splint. We talked about it already. It was invented in the 80s by Dr. Sam Scheinberg. He was a trauma surgeon in Vietnam and a board-certified orthopedic surgeon. He wanted a splint that was lighter, simpler, more versatile than traditional wooden or rigid splints, especially for wilderness rescue and military medicine, which makes sense with his background. Like you were saying, the design was inspired by aircraft structural principles and also the idea of playing with that bubblegum wrapper and seeing that form and then trying to bring it into a larger form that could actually, be used for that application.
Yeah, and these things have proliferated everywhere. Like they are seen in everything, like all EMS, but rescue organizations like wilderness medicine. I know they use them a ton in ski patrol type stuff. Basically, if there's musculoskeletal trauma happening, SAM splint is there's probably 4 of them in a bag related to whatever needs to happen for that, like of different sizes and different for different applications. But it's the standard. It is the gold standard. This type of splint.
I did first aid in 1993, and it was get the SAM splint, and we just did recently in 2026 finished our EMT training, and it's still the SAM splint.
Yep.
So if that doesn't tell you anything, nothing does.
Yeah. So it's a great tool.
Yeah.
Moldable splints, super versatile. They can be used in a bunch of different types of injuries. Even the large ones can be used on smaller injuries. Like, you can use them for a bunch of different stuff. It is an essential part of the EMT kit.
100%.
And we are honored to kind of show these and to work with Sam Medical and to be able to call them our sponsor for this episode and this section of the podcast. Great people. So thank you.
And finally being able to put it out there.
Yeah.
know?
We've been waiting a while trying to
Yes, we
get to
have.
this episode just to kind of talk about the cool things that they sent us and taught us about SAM splints and just how versatile it is. Well, okay, that is our tool of the trade for this week, which leads us to our final segment.
Yes.
With the one, the only Jonathan Aldridge.
Our student tip of the week, transitioning into student test prep.
Student test prep.
I've got some questions for you guys.
Nice.
So one thing I'm going to be doing, I'm going to change the questions up a little bit here and there, but Pocket Prep is, again, a great resource. So I picked the question of the day from Pocket Prep, and I wanted to see if you guys could get this question right.
Okay.
The pressure's on.
All right.
Considering
So
we're
the
already
question-
providers, we can only lose. No.
So the question of the day is, what are the differences between diabetic ketoacidosis, DKA, and a hyperosmolar hyperglycemic state, HHS? And there are 2 answers that are correct out of 4 possible answers. So answer 1 is HHS is more common in individuals with type 1 diabetes. Answer 2 is ketones are typically present in both DKA and HHS. Answer 3 is blood glucose levels are higher in HHS. Answer 4 is HHS is more common in individuals with type 2 diabetes. And remember, there are 2 that are correct.
I have a confession to make. Before this question, I have never heard of HHS.
Okay.
That was not, we were not, like, this is one of those types of questions where you're like, oh, that wasn't in the scope, or maybe it was a footnote in a chapter somewhere, but I'm going to be honest, I've never encountered HHS before. Have you?
Yeah.
Oh, okay. Well, I guess I just shut my brain off that day.
Well, you weren't there for that.
Oh, I wasn't there.
That was
day.
one of those ones that you were not.
I missed it because I was at EMS World Expo.
So you're more than welcome to back out of this.
No,
I know what my answers are. But.
Okay. So the difference is, and let's talk through it, because that's
sure.
I'm just because I haven't heard about it doesn't mean I don't think I can
right.
work my way through it. So the question is HHS versus DKA, right?
Mm-hmm.
Diabetic
Correct.
ketoacidosis. Okay. And one of them is, based off of context, something that may be associated with a certain type of diabetes versus diabetic ketoacidosis, which, as far as I'm aware, wasn't necessarily any particular type of diabetes.
Correct.
Okay.
Yeah.
So what were the answers one more time?
So HHS is more common in individuals with type 1 diabetes. That was answer 1. Answer 2, ketones are typically present in both DKA and HHS.
Pause there.
Was answer.
So 2 is one of the ones that I think I ruled out.
Right.
Because I think ketones are only present in DKA.
That would be one of my guesses as well.
So as far as the idea of like these answers and ruling out the ones that are looking for the ones that are incorrect first, I think that's definitely one of the ones that's ruled out.
Okay.
Yeah.
All right. So we're striking 2 from the board. Answer 2 from the board.
Uh-huh.
Okay.
I'm with you.
Yep. All right. So 3.
All right. Answer 3, blood glucose levels are higher in HHS.
That should be true. Because it's hypo. No, hypo.
No,
hypo.
it's
What?
both of them are high sugar. I would not be able to make a definitive guess on whether or not the levels are higher in one versus the other.
Okay.
And what was the fourth one?
The fourth one is HHS is more common in individuals with type 2 diabetes.
So 1 and 4
Yep.
are contradictory.
They
Correct? Okay.
That is
So
correct.
it has to be one of those, and it has to be 3.
Yes.
I would say, actually, I don't know if it's type 1 or type 2. I would just take a guess and say type 1 and question 3 based off of elimination of context clues.
Yeah, and I went with 1 and 3.
So 1 and 3 would be my final answer.
Okay. So you got answer 3 correct, right? But it is one of those 2-part questions where you have to get all the answers correct.
So it's all or nothing.
All right. So answer 1 is incorrect. It is actually more common. HHS is more common in individuals with type 2 diabetes.
Okay.
Right. And so let's talk about some of the key differences between them. Right. So DKA is characterized by hyperglycemia, metabolic acidosis, and the presence of ketones. Right. So you were on the right track, Max. And then HHS, you get hyperglycemia, but the levels are much, much higher. And so you may have a blood sugar that's between 600 and 1,000, right?
Wow. Yeah.
So your meter may just read high because we may only go to 500 or 600 on a blood glucose meter on the ambulance. And so you also have high serum osmolality. And here's one big one: profound dehydration without ketone production. Right?
Okay.
Mm-hmm. So
because profound dehydration and like dry mouth and all that stuff, those are indicators of hyperglycemia in general, correct?
Right.
Yeah.
Also the timeline may be a thing. DKA usually within 24 hours of that hyperglycemic state, and then HHS is going to be over days or weeks as well. So,
Gotcha.
yeah. So those are a couple of the differences.
Well, strike one for me.
That's okay. Hey, no, that's okay because right, we're in here to prep for a test, and so we're going to talk about the answers for.
Oh yeah,
for
this
these.
is. I mean,
right?
and honestly, we should be doing this as providers too. Like, we should be checking our knowledge. Like,
Of course.
Sure. All right. Are you guys ready for question number 2?
Sure.
yes.
Okay. All right. This is a scenario based question. So there are going to be
I love these.
4 possible answers. And so we have to pick the appropriate thing. You are called to a 73-year-old female patient's house with a history of heart disease and hypertension. She complains of chest pain and shortness of breath. She is conscious and alert with warm, dry skin. Her initial vital signs are within normal limits. What is the most appropriate initial intervention? 1. Place her in a comfortable position and administer oxygen. 2. Assist in the administration of low-dose aspirin. 3. Apply automated external defibrillator AED pads. 4. Assist in administration of nitroglycerin sublingual.
Oh, it's absolutely going to be apply the AED pads right now. I love those ones. I'm like, well, it's not that one.
So I'm going to read the question. Question again.
What did she present? What's her chief complaint?
So you're called to a 73-year-old female patient's house with a history of heart disease and hypertension, and she complains of chest pain and shortness of breath. She is conscious and alert with warm, dry skin. Her vital signs are within normal limits. What is the most appropriate initial response?
Okay, so
Do you want me to go first on this
yeah,
one?
go.
I would say that of those options, AED's out.
Yep.
Because you only do that when somebody's in cardiac arrest. The position of comfort and oxygen seems like it would be, oh, well, that doesn't seem very bad. However, she doesn't have any indications of needing oxygen. It didn't say that she has any shortness of breath.
Well,
and
It did actually. Nope. It does say she has shortness of breath.
it does. Okay, I missed that. Sorry. It's hard to do these when you don't have the words in
To
front
read
of you.
it?
Yeah,
Yeah,
to
it's
read
tough.
the questions. Okay, so shortness of breath. Okay, that changes my answer then, because the other two are interventions for indication of cardiac chest pain chest pain of suspected cardiac origin. So aspirin and nitroglycerin. I would say that being that there is a potential life threat in having shortness of breath, we should apply oxygen first. That would be my gut reaction to that.
So
However, it's a toss up between that or aspirin.
yeah, so that's what I was thinking. It's an immediate intervention, right? So to me, the application of the aspirin kind of is a red flag as an immediate intervention. So for me, I think I would land on the aspirin.
Yeah,
Okay.
I could see either. This is
Yeah,
one of those
it could
kind of
be either
tricky
one of those.
test questions, because it's like it's obviously leading you into a cardiac patient. So my rationale is she is having shortness of breath,
Right.
difficulty breathing. That is something I need to worry about first before moving on to interventions that are not immediate life threats.
Got it.
Which that
Yep. Yeah, I completely see the rationale on it.
Okay. All right. So you guys split, or what? So your answer
I
one,
think-
Mike.
Yeah, I'm answer one. Oxygen and position to help with breathing.
Yep. And I'm on the aspirin train.
Okay. All right. And so the correct answer is answer 1, right? You're going to place her in a position of comfort and administer oxygen, right? The thought process being that the airway breathing circulation airway comes first. So we want to deal with that shortness of breath as appropriate. Now, here's the thing. Max, that's absolutely something we're going to do for her because she is having chest pain,
Right.
as well as the assist with the administration of nitroglycerin if we have it available to us.
Yeah.
So
But-
And there aren't
right.
contraindications for it, like a low blood pressure.
Right.
correct.
The
It did say her. It did say her vital signs were within normal limits. So we will
Yep.
assume that she has a blood pressure that is not contraindicating the administration of nitroglycerin.
It didn't say that she hadn't taken erectile dysfunction meds, though. So
Well,
Hey,
right. That's
women
we
do
could
take
have
that.
to rule that
yeah,
out.
Just saying.
yeah. Well, I'm just just going through all the contraindications.
Yeah, right.
But yeah,
right.
I think that one's tricky because I've seen that same question presented
Yep.
in slightly different ways, and that's one of those ones that'll trip you up because it's like, oh well, you got to look for the breathing thing.
The breathing
because as soon
thing
as you
is
say,
it.
"Oh,
Yep.
there's a breathing problem," now it's a primary assessment issue, a
Yep.
life threats issue
Right.
versus a
Yep.
okay. If that wasn't there, then we're talking. Well, it's that if there was no breathing issue, oxygen wouldn't be indicated because there's nothing to say that she needs it. Then
Right.
we would move down to aspirin because that's usually comes before
The
nitroglycerin. And then we would only be able to give the nitroglycerin if it was her nitroglycerin
Right.
on our scope.
Yes.
So,
Sure.
yeah. Anyway, that's a tricky one.
Yep.
You got to think through them.
Yeah, absolutely. All right. I've got one more if we have time for it.
Yeah, let's do it.
All right. Okay. You are assessing a child's vital signs at a local elementary school. Which of the following would be considered a normal set of vital signs for a healthy 8-year-old child?
I don't think we have
All
time
right.
for this question. It's been great having you all on.
Great
the
having
right
you on. And from now on, we're just going to print these questions out.
No,
and
go.
them
Let's
on
do
your own.
it. Let's hear the what normal vital signs for an 8-year-old.
Okay, so answer 1. Respirations are 16 breaths per minute, a pulse of 58 beats per minute, blood pressure of 190/70. Okay.
No.
Answer 2. Respirations are 12 times per minute, a pulse of 130 beats per minute, blood pressure is 100/72.
Next one.
Okay. Answer 3. Respirations are 35 breaths per minute, a pulse of 58 beats per minute, and the blood pressure of 128/66.
No. Next one.
Okay. Respirations are 20 breaths a minute, a pulse of 98 beats per minute, and a blood pressure of 104/73.
Bingo.
That's the one.
You are correct.
Only because normal, kids have vital
Yep.
signs that are elevated from adults.
Yep.
Now, I wish I was more up to I wish I could cite the exact ranges. I know we should. We
should.
really, really should. But I'm going by what I know, and then if they're of older, school age children, they're a little bit closer to what adults are, and then the younger they get, the farther away from those
Yeah.
vital signs they get. So the two in the middle, or the first three, basically had their vital signs. Their heart rate should never be lower than an adult's heart
Yeah.
rate.
Right.
So heart rates in the 50s or the third, or I think it was 60s or something like that. Those are lower than the standard adult heart rate.
Right.
So those eliminate right away.
Yep.
One of them had
The second choice was closer.
one of them had a blood pressure of 190 over
I know.
70 or something like that, and I'm like, that's definitely not normal.
No.
That's that kid.
Right.
That kid's on meth. I don't
Yes, he
know.
is.
But that one was eliminated. So it's just trying to find the ones okay, what's the principle that I know? I know that kids have a slightly elevated respiratory rate and heart rate over adult rates, and that spread gets bigger the younger they are. And then how can I use that to help kind of eliminate some of these, and then hone in on the right question.
And
That was my rationale.
And listening to all
Sure.
those, the breaths and the heart rate was what did it for me.
That's
That
that's
was
kind of
that
the
was
thing with pediatrics. They're going to have a higher baseline respiratory rate and a higher baseline pulse rate,
Yep.
heart rate, and then their blood pressures are going to have a lower baseline normal than an adult's would.
Mm-hmm.
Yep.
So
Yeah. So, I mean, work the problem.
yeah, and like we've talked about the whole time, and we're going to continue to talk about, this testing aspect of things is its own skill, right? So, well, good job, guys.
2 out of 3 ain't bad.
Yeah.
As
Yeah,
Meatloaf
I mean,
would say.
1 out of 3 for me.
Because 2 out of 3 ain't bad.
He's singing again, people. It's happening.
Don't be sad.
He's delirious. That's why he's singing.
Yeah, Meatloaf he was awesome, by the
He
way.
was.
I don't
Meatloaf. Yeah, Bad Out of Hell is a great album.
Bad Out of Hell is the most badass, like oldies rock album you can ever imagine. Like, I know we're deep into the podcast on this one, but man, if you could pull one little tidbit out of here, be like, you know what? Let me give Bat Out of Hell a listen. Holy shit!
Yeah,
like
it's a great album.
Oh my god, Bat Out of Hell itself.
Yep.
Paradise by a Dashboard Light. I know it's overdone in karaoke.
I can't exactly. Like I when that song comes on, I have to change the channel because I went to karaoke bars for a lot of years, and it was like one of those default songs for a couple to sing. It's like, oh God, kill me now. Is it? And it's a long song. It's long as hell. Yeah. So, but anyway, that
and nobody sings.
I would do anything for love, but I'm not going to do that.
Yeah, exactly.
Yeah. I don't think that's not that album. I think that's Back Into Hell.
Maybe
I would do anything for. I think. I could be wrong.
The question is, what doesn't he want to do? He never tells.
He's not going to do it though. That we know that.
Do it though.
But yeah, he's drawn his line in the sand. Right. He's not doing it.
Anyway, great questions.
Yes,
great questions.
Yes, thank you, sir.
Section. And if you're listening to this, we would love to know how you're doing as we go through and do these questions. Like, how are you making out with them? What's your rationale to your answers? We'd love to hear from you.
Yeah, and hopefully us talking through them and being vulnerable and showing you that, hey, we don't know everything.
Nope.
Although we've passed, hopefully that gives you a little bit of inspiration, a little bit of confidence, because you deserve it. If you're listening to this, you're going after it. You're going to school. You will make it. We believe in you. So,
exactly.
All right. With that, why don't we wrap this thing up?
Yep.
Sound good to you guys?
Sounds good.
Stay tuned in a couple of days after this release. Because of that fantastic interview. Yeah,
make sure if you're in, well, you should be interested, because Bob is a really great guy. I hope you all listened to his interview. We had a great time chatting. I think you will find a lot of insights into his approach, and he had some really good sage advice for new providers coming into EMS.
Yeah.
Great stuff. But listen in. Bob Waddell, the next episode after this one. But until then, thanks for taking the journey with us, and we'll see you next time on the Ride Along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing.